I would now like to request the chairpersons to introduce our honorable speaker of the session, Dr. Kalpana Luthra ma'am, Professor and Head of Department of Biochemistry, AIIMS, New Delhi.
So now I would like to welcome our esteemed speaker, Dr. Kalpana Luthra ma'am. She's a professor and head of Department of Biochemistry in prestigious AIIMS Institute, Delhi. She has been awarded the Fogarty Fellowship in 2002. She's a recipient of FAMER Fellowship in 2006 and was awarded the Shakuntala Amirchand Prize awarded by ICMR for the year 2003. She's a fellow of Indian National Science Academy and has more than 150 publications and many chapters. She has many patents, and she's a recipient of AIIMS Excellence Research Award in Basic Research thrice. So over to you, ma'am.
A very good morning to all of you. At the outset, I wish to thank Professor Suman Bala Sharma, the organizers, and Sharda University to have me here to give a talk at this wonderful gathering and university. So my talk is primarily focused on how HIV, when infecting the individuals, and what are the immune responses elicited by these individuals. So almost every HIV-infected infant, child or adult infected with the virus is able to elicit antibody responses. However, it's just 1% of this entire infected individuals who are able to elicit neutralizing antibodies. So for the benefit of the UGs, I would like to briefly say what is a neutralizing antibody. These are basically only those antibodies which are able to bind to the pathogen and block it from infecting another cell. And HIV being very diverse due to the non-ability of the reverse proofreading activity of the reverse transcriptase enzyme, and also the virus envelope constantly undergoes changes due to altered glycosylation patterns. So due to these various factors, there is a constant struggle between the virus and the host immune response, and that is what decides the course of the infection. And all of you would be aware that this virus mainly infects CD4 positive T lymphocytes and the macrophages. And when the CD4 counts go below 200 cells per microliter, it leads to acquired immunodeficiency syndrome. So as you would see, this virus is comprising of an envelope glycoprotein, which is trimeric in nature and heterodimer, and it has a viral nucleic acid. So till date, there is no effective vaccine against HIV, and antiretroviral therapy, which is given according to the National AIDS Control Organization and the test and treat policy. The moment an individual or an infant is diagnosed to be HIV positive, is initiated on antiretroviral therapy. So this therapy is able to reduce the viremia and delay the disease progression. However, it cannot prevent infection, and neither can it prevent latency. Some of the virus enters into lymphocytes and macrophages and becomes dormant. And later, when these dormant viruses get reactivated, then again you have infection in that particular individual. Therefore, it is very important to have an effective vaccine that can block the virus. A number of immunotherapy, like neutralizing antibodies, are also being tried in clinical trials. And you may be aware of ibalizumab, which has been approved by FDA to be used in individuals who have failed the first and second lines of therapy for HIV-1. So why is it that every infected individual is able to elicit responses but not protective responses? So you can see here that during the course of development of the B lymphocytes in the bone marrow, you have the immature B cells in a healthy individual which are released into the peripheral circulation and turn into naive mature B cells, and when they encounter any pathogen, they get activated against that particular pathogen, form plasmablasts, and the plasma cells secrete antibodies which combats the infection, and once the infection recedes, you have the development of resting memory B cells. However, in HIV-infected individuals, One of the causes due to the decrease in the CD4 counts, since the virus, each time it lyses out of the T lymphocytes, you have a drop in the CD4 cell count. So because of which, there is no T cell mediated B cell help, as a result of which, many of the B cells, due to persistent antigenic stimulation and chronic infection in these individuals, so there is more and more release of B cells from the bone marrow, and therefore you have raised number of immature transitional B cells, and instead of activated mature cells, you have more of exhausted tissue like memory B cells and less of the resting memory B cells, which are decreased during HIV infection. So due to these aberrations in the immune responses, the body is not able to effectively clear the viremia. So Dennis Burton proposed a reverse vaccinology strategy wherein what you do is you screen the HIV infected individuals, simply take their blood plasma where you know there are antibodies, test these plasma against the viruses, pseudoviruses which are there in the laboratory, and see if these antibodies are able to neutralize those viruses. Then that would show that particular individual has protective antibodies. So then what you do is you go on to draw the blood, separate the peripheral blood mononuclear cells, and by B cell sorting and other methods, you can isolate broadly neutralizing antibodies. And once you identify and characterize an antibody to be broadly neutralizing, broad meaning that antibody is not only able to neutralize the autologous viruses which are circulating in that individual, but also able to block or prevent infection by various strains of the viruses. So in India, it's primarily clade C viruses, and in the Europe and the North America, it's primarily clade B viruses, and in the other regions like China and East, you have circulating recombinant forms. So the broadly neutralizing antibodies, or the BNAbs in short, are effective against these broad spectrum of viruses. So once you are able to successfully isolate such an antibody, you map the epitopes which it recognizes on the virus envelope, and those epitopes can form the basis of a vaccine design. So these are the various vaccine strategies that are being tried out, that all of us inherit the germline B cell which have B cell receptors, right? These are naive B cells, and so when you have a chronic infection, the virus has evolved so much that those chronic viruses cannot be recognized by the naive B cell receptors. So therefore, what you need to do is you need to identify the founder viruses which are found early during infection, which are able to trigger those naive B cell receptors and then direct the B cell response to develop a broadly neutralizing antibody. So some of the strategies are shown here. Epitope targeted vaccine design. So you have HIV trimer on which you have different V1, V2 regions, which are the variable regions of the virus. Within those, there are conserved epitopes. So based on that, you build a simian immunodeficiency virus in which you insert these epitopes from the HIV, and based on that, you are able to have a V2 engineered SIV trimer, that is a simian immunodeficiency virus trimer, that can bind to V2 BNAb directed inferred germline receptors. And how will you test whether this trimer is effective in eliciting an immune response? It is by immunizing mice which are engineered. These are knock-in mice in which you have knocked in the germline B cell receptors of human origin, which can recognize these V2 epitopes. So this is how overall you can have an epitope targeted vaccine design. There are other strategies for vaccine design, such as the sequential immunogens, wherein, as I told you, in the primary immunization, you use a very less mutated virus-based trimer immunogen, which can bind to the naive B cell receptors, which are present at germline. And then, when you do the boost of these animals, what you do is you have more complex antigens, which will trigger and divert the B cells to develop broadly neutralizing antibodies. Apart from this, you also have lineage-based vaccines for inducing V3 glycan-directed antibodies. So as I told you, the virus is covered by a complex glycan. Multiple glycosylations are there on the surface of the virus envelope. So what you do is, the initial prime of the vaccine, you give by a trimer in which you have removed the glycans, and then followed by boosters by restoring the glycans, which will then steer the immune response to give you a protective antibody response. So to come back to why our lab focused on the immune responses elicited in infants and children during HIV infection. So there is a lot of difference in the HIV infection during perinatal conditions and in adult HIV-infected individuals. So all of you are aware that the CD4 counts are very high in children, like as you go from age 1 to 5, there is a decrease. Initially, that's why I measure it in terms of CD4 percentage, and later on in adults, we do it in terms of CD4 counts. So more the number of CD4 cells, more the virus has cells to infect. And therefore, you find that in HIV-infected infants, the viremia is very high as compared to that in the adults. So there is chances of rapid disease progression because children have an immature immune system and are not able to combat the viremia. Whereas in adults, the disease progression is slower. It can range from 5 to 10 years till the times an infected individual will develop into full-blown AIDS. More than 50% mortality is observed within 2 years of birth in the absence of antiretroviral therapy during vertical transmission. Therefore, according to the NACO guidelines these days, the moment an infant is found to be HIV positive, they initiate ART. And in adults, approximately 40% mortality is seen within a 10-year of infection in the absence of ART. And less than 5% become long-term non-progressors. So what do we mean by long-term non-progressors? That in the absence of antiretroviral therapy during the earlier times when ART was initiated later, when the CD4 cells went below 500 cells per microliter. So long-term non-progressors are those individuals who even without therapy are able to maintain stable viremia and stable CD4 counts without the drop in the CD4 counts. So infants infected via mother-to-child transmission in more than 99% of the infections in children with a well-defined genetic bottleneck leading to infection with a minor variant. So what does this mean? That it is observed that maternal antibodies, the mother who is infected with HIV elicits maternal antibodies, wherein those antibodies are able to block most of the dominant viruses. So it is hypothesized that because of this genetic bottleneck, it is only the minor variant which gets transmitted onto the infant, and therefore that can serve as a founder virus in the infant and evolve along with the immune response in the infected infant. So in our lab, we wanted to see what are the viral factors associated with the induction of broadly neutralizing antibodies. So before the revision in the NACO guidelines, when ART was initiated only when the CD4 cells dropped below 500 cells per microliter, we had a cohort of HIV-infected children whom we followed up for more than 5 years in our laboratory. And out of that cohort of chronically infected children, we identified a pair of genetically identical twins who were having identical HLA haplotype. And you see here, from the visit of 78 months to 138 months, over these 5 years, they maintained stable CD4 counts, which did not drop below 500 cells per microliter, and therefore they were not initiated on ART. So we did a longitudinal analysis of the immune responses and the evolution of the virus alongside to see what are the changes. So you need not try to read the numbers, which is not possible, but you can see the change in the color. You have this particular donor 329, one of the twin, and the other twin was 330, followed up from 78 months to 138 months from left to right. And in the right panel is the other twin. You can see more of reds on the right side, showing that despite being genetically identical twins, one of the twin was able to elicit a robust neutralizing antibody response. So elite plasma neutralizing activity was observed in both twins. The potency and breadth of the BNAbs evolved with time in this particular donor 330 but not in 329. So we went on to ask what are the factors which is influencing this diverse immune responses. I'm not going into the details. We defined the neutralization scores, and you can see here the 330 donor continued to have neutralizing activity, high neutralization scores even after 90 months, up to 138 months, which continued to evolve, whereas in the other donor, it stopped falling after 90 months. So then we tested this against diverse panel of viruses, Indian, South African viruses, and also clade B viruses. So next, what we did was, we tried to see what are the regions on the virus envelope these protective antibodies are developed against. So these are the various mutants that we generated in the viruses, and based on that we tested these plasma antibodies, and we observed that the plasma from both the twins showed evolution of V2 and V3 directed broadly neutralizing antibodies, suggesting that BNAb development in both the twins may be determined by specific sequences on the viruses that were shared, and this can guide immunogen design. So next we went on to see what are the susceptibility of the viruses circulating during natural infection in these twins, whether they are susceptible to neutralization by these V2 and V3 antibodies. Out of these, we found one virus in one of the donor and the other virus, you can see here, these viruses were susceptible to neutralization by all the known broadly neutralizing antibodies and also to the plasma antibodies from these donors. So these form good templates for a vaccine design, because tomorrow whenever you have a vaccine and if it is immunized in individuals, then that immunogen is supposed to bind to our B cell receptors and stimulate the responses. So unless you have these viruses that are neutralized by these broadly neutralizing antibodies, they will not form a good template for a vaccine design. So majority of the viruses evolving at later time points developed resistance. Can you see these white areas? So with time, this is the time duration, 90 months, 112, and also 117 months. You can see as the time evolved, there was more resistance of the viruses to neutralization, so they have developed resistance. So next we went on to sequence each single genome amplified virus and looked for why with time these viruses are developing resistance to the neutralizing antibodies. And we observed that one of the important residues is mutated in the virus, as a result of which this virus is becoming resistant to V2 glycan antibodies. Apart from that, you can see here these dotted lines here. These are the conserved regions, but these are the new insertions. So there is a V2, V4 loop lengthening in the viruses, because of which the viruses are becoming resistant to the co-evolving antibodies. So you can see here there is a loop lengthening in the V1, V2 region and also in the number of potential N-linked glycosylation sites. As I told you, these viruses keep on changing their glycan patterns. So that is the reason that most of their immune responses are ineffective and vaccines are not very successful so far. So next we went on to see, as I told you, that in infants there is a better chance to identify a founder virus which can serve as a prime immunization immunogen, and therefore we characterize these 47 infants for the presence of plasma antibodies, of which 4 of them showed good plasma neutralizing activity. We extensively characterized them, and these showed that we developed a modified breath potency matrix for infants for the first time, because so far what was published was globally, it was only for adults. And in children, due to the immaturity of the immune responses, their response strength is also lower. So we developed a modified breath potency matrix with our data and showed that strong neutralizing activity were found in these 4 elite neutralizers. Next, we went on to do the epitope mapping of these plasma antibodies. Again, there were V1, V2 glycan antibodies, which were early initiated. So, both our studies in infants and in chronic children, we found that the earliest immune responses are against the V1, V2 region of the virus envelope. So, V2 apex targeting antibodies predominated in these infants. So then we went on to characterize the sequences and found that why only those 4 out of 47 children were very effectively producing protective responses. That is the reason was that in these 4 infants, we found multivariate infection. Like you can see in this phylogenetic tree, there is a lot of genetic diversity in the circulating viruses. So this we characterize by performing single genome amplification of the viruses, not going much into the detail. So you can see here there is a maximum envelope genetic divergence in these elite neutralizers as compared to all the other infants. So to summarize the findings of these studies in HIV-infected infants, we found that plasma neutralizing antibodies in these infants with multivariant infection targeted both variants, which were due to multivariant infection, suggesting that envelope-specific antibodies generated in the context of 2 distinct viral variants can target conserved regions on both the envelopes. So our data provides key evidence for exploring polyvalent vaccination approaches for pediatric HIV-1 infection. So from the donor in which there was persistent neutralizing antibodies with time, 330, we generated a broadly neutralizing antibody, Ames PO1, right? So this was done by HIV-specific single B cell sorting.
We're running short of time.
Yeah, I'll quickly give an overview. So we generated a broadly neutralizing antibody, extensively characterized this antibody for its ability to neutralize the viruses, and found that this antibody had undergone affinity maturation and could be used as a potential therapeutic antibody. So this study further improves. Then we went on to see how this antibody evolved with time, and we found that the antibody acquired more and more SHM and affinity maturation, and suggesting that it can be used for a vaccine design in future and for immunotherapeutics. So now currently in our lab, what we are trying is those 2 viruses which I told you in these elite neutralizers, based on that we are trying to generate immunogens which can be used for testing for their immunogenic potential. So we extensively characterize these viruses. We did a structural analysis, and we found that multivalent presentation of these immunogens is better able to elicit immune response in the rabbit. So we have carried out rabbit vaccinations, and we also did the binding analysis extensively and found that when we increase the valency of the immunogen by having presenting it on nanoparticles, you have better immunogenic responses. So the clade C SOSIP envelope trimer that we generated on multimerization showed improved antigenicity and immunogenicity when tested by immunization in rabbits. So this is a novel engineered envelope glycoprotein that we are taking forward for trials. So all the study would have been impossible without my PhD students, MD students, and a number of the project staff, number of collaborators, NIH AIDS reference and reagent program from where we get most of the HIV reagents free of cost, and all the study participants without whom these studies would have not been possible, especially the twin follow-up which we did for 5 years who were ART naive. So that was a time when we could manage to study it when they were in ART naive condition. So, and the funding agency, Department of Biotechnology and DST, Indo-South Africa Collaborative Project. So without these, our study would have not been feasible. Thank you so much.
Thank you, madam, for giving a very interesting talk on HIV. Professor Luthra is doing work on HIV from past 1 decade, and it's an excellent piece of work. Thank you, ma'am. So antibodies have a potential to block the HIV replication by multiple pathways, I think so. What is your comment on this?
So in recent human clinical trials, it has been shown that during early infection, if there is a combination of monoclonal antibody VRCO1, this has been tried in human clinical trials. So when VRCO1 is given along with antiretroviral therapy, it is able to block the viremia up to almost 2 months. But the only challenges are that you need a large amount of neutralizing antibodies, like 30 milligram per kg body weight. And therefore now there is further clinical trials using cocktails of antibodies targeting different regions of the virus envelope.
And these antibodies are monoclonal antibodies.
These are monoclonals.
Thank you, ma'am. Thank you. Any question from the audience?
Thank you, Dr. Kalpana.
I think there's a question here.
There's a question? Yeah.
Madam, there was a world news that Lenacapavir is the medicine which can cure the resistant HIV virus. I want to know your uptake on this topic. And now the FDA has improved EBI 101 as a vaccine. They are trying. So what your comments?
So there are a number of vaccines being tried, and because of the rapidly mutating viruses circulating in the individuals, so maybe you need not just one vaccine, but a combination of multivalent vaccines. And nowadays there is more evolution in terms of how you present the vaccine, because it rapidly gets cleared. So on nanoparticles or so that it presents better to the immune system. So these are all under trials, because so far there is no effective vaccine.
Any more questions? Thank you for this talk. Being a pediatrician, we are the end users for the vaccine, and this is a good bird's eye view on how much work goes on in vaccine design, which is actually a very exciting area of research.
Thank you.
So thank you very much for this talk, and this would be useful also for other vaccines to be made which are like in pipeline for cancers and even autoimmune diseases.
Absolutely.
So very nice talk.
So
Thank
here
you.
I would just like to add that during COVID-19 pandemic, we also studied that these broadly neutralizing antibodies, one of them was cross-reactive with the SARS-CoV-2 virus. So we published that in PLOS Pathogen. Due to paucity of time, I did not include that data here. Thank you.
Thank you. On behalf of everyone here, we extend our sincere appreciation to Dr. Kalpana Luthra ma'am for such an informative and insightful session. I would now request the Dean ma'am, Dr. Supriya Gupta ma'am, and the chairpersons to felicitate Dr. Kalpana Luthra ma'am. I would now request Dean ma'am and Dr. Supriya Gupta ma'am to felicitate our esteemed chairpersons. Thank you all for your valuable time. After such an intuitive session, let us proceed further with the fourth session on the theme, Chronic Pelvic Pain, Thinking Beyond Gynecological Disorders. To chair the session, I'm honored to invite our esteemed chairpersons, Dr. Veena Vidyasagar Ma'am, Professor of Department of Obstetric and Gynecology, SMSR, Dr. Ashok Bhatnagar Sir, Professor of the Department of General Surgery, SMSR, and Dr. Ruchi Srivastav Ma'am, Professor of the Department of Obstetric and Gynecology, SMSR, on the dais. I would now like to request the chairpersons to introduce our honorable speaker of the session, Dr. Banju Puri Ma'am, Director Professor of the Department of Obstetric and Gynecology, LHMC, New Delhi.
The speaker of this session needs no introduction. She is the teacher of teachers, and I'm honored to chair this session when my teacher is the speaker. Thank you so much, ma'am, for coming over. Dr. Manjipuri is a professor director in the Department of Obs and Gynae, Lady Hardinge Medical College, New Delhi. Ma'am is expert of many various committees. To name few are Central Drugs and Standard Control Organization, member National AEFI and Signal Review Committees, External Quality Assessor in Public Health Facilities. Ma'am has received many awards, and there's a long list of these awards. She has received the Achiever Award in FOXY 2023, APG Abdul Kalam Excellence Award 2023. Ma'am has many publications, more than 175, and 2,100 citations. She has interest in quality improvement, public health, reproductive endocrinology. Ma'am has edited many books. These are just few books over here written, but she has many chapters in various books as well. We welcome you, ma'am, for this session. Thank you.
Thank you, Ruchi, for a very kind introduction, and thank you, Archana and Team Sharda, for inviting me for deliberating on this topic of chronic pelvic pain, looking beyond gynecological problem. After a very intense talk and sharing of wonderful work by Dr. Kalpana, I think it is more of a common problem which we are going to discuss, and it extends across multiple specialties, and I think that is the theme of the program today. So now, if we look at chronic pelvic pain, how do we go about defining or understanding the term chronic pelvic pain? So it is a symptom which may represent a specific pathology, or it may be a chronic pain syndrome, wherein you don't find a pathology, or it could be a combination of the both. It usually refers to pain which extends from the level of umbilicus till the level of inguinal ligaments usually. So that is the area where the patient can have pain, and we know there are multiple organs in that area. So it is not that it is always related to the uterus and the tubes and the ovaries. It could be the bowel, it could be the bladder, it could be the musculoskeletal structure. So it could be anything. But the thing is that whenever a woman comes to us, I am a gynecologist, so I'm going to referring to women, but I'm sure chronic pelvic pain is common in men as well. Right? So chronic pelvic pain syndrome is a condition where there is no identifiable etiology other than the pain, and is due to changes in the central nervous system. Here, actually, the pain, the peripheral pain gets processed by the central nervous system in such a way that it's, the pain sensation gets aggravated. So that is also known as centralization of the pain. So there is increased, enhanced response to the pain stimulus. So that is what is chronic pain syndrome. And because every time the pain gets provoked, even with a minor stimulus, so it interferes, it disturbs the patient so much, that when she goes to a doctor, they say, everything is okay, I can't find any pathology, but the patient is suffering. She's suffering because of this exaggerated response. So it is a complex process, and we all need to understand as to, it is something which we need to kind of address in totality. The reported prevalence worldwide is about 6 to 25%, and only 1/3 seek medical care, because they stop seeking medical care because whenever they have a huge, file of investigations, and when they go to a busy gynecologist or a busy surgeon, so they would say, kuch nahi hai, everything is okay, all is well, so fine, they just kind of refer them. Aise hi lag raha hai, psychology hai, psychological hai, and things like that. So the end, we need to understand that is the end symptom of multiple potential overlapping etiologies. So that is why no single clinician can treat it. And each of these pathologies would contribute to the pain and require management individually. And gynecological causes would account for 20% of cases of chronic pelvic pain. Now, going to specific definition, there is lack of consensus as far as the definition is concerned. It refers to chronic or persistent pain perceived in structures related to pelvis, right? Usually below the level of umbilicus. The duration mostly accepted is more than 6 months, but one can start looking at the patient even if she's having continuous pain for 3 months. It is something which significantly impairs the functioning of the woman at home or at her workplace, so it is disturbing her functioning. It requires treatment, and it is unrelated to pregnancy, right? So it does not include the pain which the pregnant women would have because of stretching of the ligaments. So it may be intermittent or continuous. It does not occur exclusively with menstruation or with intercourse. There is incomplete relief with most treatments, and it may be associated with urinary gastrointestinal symptoms. It is definitely associated with impaired quality of life and causes mental health changes in the form of anxiety and depression. So that is the picture of a woman who has got chronic pelvic pain. Again, re-emphasizing on the fact that chronic pelvic pain can be associated with specific disease which is curable and treatable. So it does not stay for 3 months or 6 months. So if a woman has infection or the woman has any, malignancy related pain, of course it can be chronic in those cases. We know the cause, or there is any local pathology. So that is, one aspect of chronic pelvic pain, but what is more bothersome is you do not find any pathology, and it is chronic pelvic pain syndrome, where there is negative cognitive, behavioral, sexual, and emotional consequences, and symptoms are related to dysfunction of the urinary tract, GIT, and genital tract. All this gets mixed up. She says she's got pain. She does not know where is the pain, right? So when we have to treat these patients, we need to understand that we have to follow this integrated, stages integrated model, wherein we must understand that there are biological events which are sufficient to initiate nociception, initiate the pain, and it is also leading on to alterations in the lifestyle and relationship over time. Fine, so that aspect also has to be, so it has got a psychosocial angle as well. And then, of course, the anxiety and affective disorder, which also need a psychiatrist to come on board and treat that aspect also. Unless we treat all these things, the patient cannot be cured. So looking at the various causes of chronic pelvic pain, what are the various causes which can lead on to this? So we have gynecological, urological, we have gastrointestinal, musculoskeletal, neurological, and sometimes vascular. So there is a whole plethora of things which can give rise to chronic pelvic pain. But to list a few which are most important are endometriosis, interstitial cystitis, and irritable bowel syndrome. So these are the ones which are usually interrelated, and the patient can have a combination of all these, and we need to actually evaluate the patient as far as all these problems are concerned. So when I'm talking about the chronic pelvic pain beyond gynecological purview, We are talking about urological causes like interstitial cystitis, urethral syndrome, recurrent cystitis, urolithiasis. If we are talking about gastrointestinal system, we are talking about irritable bowel syndrome, then a chronic appendicitis. Sometimes it could be only hernias. A lot of patients have cesareans these days, right? So once they have cesareans, you know, there might be a small hernia which is kind of troubling her. Every time she gets up, that pain is there and it is troubling her. It could be adhesions. It could be anything. Then musculoskeletal, of course, you know, there are spasms of different muscles which are there, which do not get diagnosed because we are not looking for that, right? It could be postural problems. A lot of people are now on, you know, computers. They might be sitting in different postures. So there could be laxity, there could be spasm. You know, all these things could be contributing to the pain. And of course, neurological. Sometimes the nerves might get, you know, they might get involved in fibrosis, and there could be pain in particular positions, which may not be there all the time, but in particular positions it would be. So all these could be contributing. So how do you evaluate a patient who comes to you with a constant pain being there for more than 6 months? What do you do with that woman? So first is you have to take a detailed history. That is what is most important. And the history has to be directed towards the various causes which I have listed. You have to ask her if she's got any urinary problem, if she got any gastrointestinal problem, does she have any menstrual problem, does she have any musculoskeletal problem, or does she have any sexual problem. A large number of the times we find that women who have decreased libido, especially when they enter the perimenopausal age group, right? So they have decreased libido, and given the psychosocial dynamics, you know, she's unable to explain that to her partner, and then the only way she can put her point forward is that she comes to you with chronic pelvic pain, and you know, and then you have to kind of treat her and understand. So if you don't ask her that angle, and decreased libido is curable. I'm saying it is treatable. I can't say it is curable, but it is treatable. So you can always help her. There are various methods you can help her with that, so that the interpersonal relationship between the partners is not disturbed. Then we need to identify the exact site of pain. You know, so that means it is important to know where is the pain arising from. Then we need to know the characteristics of the pain, which would mean associated provocative or palliative factors, the quality of pain, the radiation of the pain, the setting. What are the times does she have? Does she have it in the evening, or does she have it when she's stressed out or whatever? And also the temporal aspects. So all these aspects, you have to go into the details of the pain. And then, of course, psychosocial history, like I've already told you. And prior diagnostic tests and treatments which she's received, we need to review all that. We should not start from, you know, start again and reinvent a circle. First, let's know what has she gone into, so that we know that this is she's already had, so don't start with that again. And also establish current impact of the pain on her quality of life. So we ask her, is it disturbing her routine work? Is she able to kind of cope up with her work at home and in the office? So, and what medications is she on? So all that needs to be asked for. And this I've already explained you. Please look at this aspect. About 40%, 30 to 40% of women who come to my practice, I see a lot of them. And you have to understand they do have some element of depression and anxiety. Is it right? So depression and anxiety is not only common in women, it is common in men as well. So we need to understand that we, being the you know, person to whom she is visiting, we need to identify it. We need to identify and take a call and treat it, right? So this is a very simple screening tool. All what you have to ask her is she kind of, does she have, she's maintaining the interest in her routine work or not? Is it right? And second is she feeling depressed? You just have to ask, mood kaisa rehta hai? Do you feel low, or are you happy? So वो फट से कह देते हैं, नहीं मैम मन अच्छा नहीं है, right? So we ask them कि आपका जितना आप अपना ability के हिसाब से काम कर पा रहे हैं, she will say no. So are you able to sleep well at night? No, right? Or yes, whatever you say. And sometimes she say, नहीं सो जाती हूँ, so induction में problem तो नहीं है, सुबह जल्दी नींद तो नहीं खुलती है, भूख कैसी लग रही है, constipation तो नहीं है. You know, small things if you ask, and you get to know that this person is not feeling well mentally. I think that is what is important. So we can use these tools which can be used by routine healthcare providers, and these are good tools. और जो पेन के साथ आता है उससे तो ये टूल आपको जरूर पता करना चाहिए. So these are very nice tools. So GAD score, that is Generalized Anxiety Disorder Score, we all can apply that, and then we can give them a proper referral. So appropriate referral, if the history is suggestive of a specific non-gynecological cause, is very important, so that she goes. And you need to have friends across specialties. सब लोग इसको नहीं understand कर पाएंगे. As a gynecologist, you need to understand it. Then you must have friends across who would also understand what are you trying to look for. Just don't send them pain abdomen. वो कुछ नहीं, एक ultrasound करा के वापस भेज देंगे. So I think that is what is important. We need to be on same page. So special attention is paid to symptoms suggestive of 5 common etiologies of chronic pelvic pain. So chronic uterine pain disorders, which could mean leiomyoma, endometriosis, or adenomyosis. It could mean musculoskeletal pelvic girdle pain and pelvic floor pain, right? So a physiotherapist also needs to be on board, and orthopedician also needs to be on board. So basically you have to have a team who should be looking after chronic pelvic pain. Irritable bowel syndrome, painful bladder syndrome and interstitial cystitis, and peripheral neuropathy. I remember my own mentor had interstitial cystitis, and she suffered so much. Everyone used to say it is functional, and she was such a strong woman. She's not going to become functional all of a sudden. And it took her almost 7 years to get diagnosed. So that is how the things are. Now, identification of the exact site of pain is important. You need to have these pictures there with you, so that she can pinpoint that these are, ask her to mark crosses, that this is the site where the pain is. So that is, and it is always a good idea when you have a patient of chronic pelvic pain, you must have a questionnaire kind of thing and these pictures. So while she is waiting, ask her to jot down everything. So there's a very nice questionnaire by I will just share that questionnaire, by the European Urology Society, so International Pain Society. So please take it out and give it. You do not have too many patients coming to you, but whosoever comes, it is important that you diagnose that problem. So one is site, and the second is the intensity of pain. She's been suffering for such a long time. All her pain, it gets mixed up. कि उसको कब कितना pain था. She will say मेरे को बहुत pain है. So you have to tell her कि अभी आप score कीजिए on a score of 10, on a VAS score, कि अभी आपको 10 में से कितने marks आप देते हैं. So then ask her to maintain that. Okay, so every time when she comes to you, try to be objective. कि अभी आपको 10 में से 0 to 10 में से कितने marks हैं, and that is a very good way of quantifying. So this is the visual analog scale, and then monthly pain scale. So when she comes to you, she will say, नहीं मेरे को सारा time pain रहता है, right? So you please first acknowledge that she's got a problem. We say we understand what you are, but let's try and understand more so that we can help you out. So please tell us right now on the score of 10, how much are you having? What was the worst in the past 2 weeks? Or 1 week or 1 month whenever she comes to you? What was the least in the past month? Okay, and what was the average in the past month? So first of all, tell her we understand that you have pain. Now we need to understand what is the severity so that we can move on. And this is important for you to understand when she comes back, that whether she is improved or she is not improved. This is what I was talking about. The International Pelvic Pain Society has a pelvic pain assessment form. Please go to it. It has a recent 2024 form, which you can look up and use it in your practice. So that is all in the history part. Now in the examination part, the primary goal is to identify the anatomical location and structures that reproduce patient's pain. Is it right? So this is not one of the patients जिसको आप बोलेंगे आप चलिए अंदर हमारे और examine कर रहे हैं, and you go ahead and examine her the same way. No, you have to reassure that you will not cause any pain to her. You have to be gentle with her. You have to be giving time to her. It is not that you're going to put in a speculum right away. You are going to first take her permission, then do gentle one-finger examination, and at the same time tell her that anytime she has pain, you are not going to kind of go further. You will stop. And same is true about abdominal examination as well, right? So general examination, you do examine the back with the patient sitting, palpate all those areas, the sacroiliac joints, the spine and everything, abdomen with the patient supine, lower extremities with the patient supine, and then of course pelvic examination, first the visual examination, then with a cotton swab. If the pain is on the vulva, then you can use a cotton swab and find out what is the point which is tender. Then a single digit pelvic examination, And then it can be a bimanual examination. And per speculum will go the last, right? Unlike what we do, right? So this is how you look at the different, you can do a digital. There are a lot of muscles. We've had patients who had levator spasm. You know, in our own practice, she had a complete perineal tear. So we repaired that complete perineal tear without going into detail. She had come to us with pain lower abdomen, pain in the perineal region. And once we closed that, we repaired it, you know, she was unable to pass stools at all. And then when we examined, the levators were in intense spasm. So it was not her complete perineal tear, it was her spasm which was bothering her, and then it took us so long to settle that spasm. So please make sure that you do all these, examinations, single-digit examinations. You should know where the muscles are, and then palpate each of the muscles and look for the spasm, and they would feel like bands, and you do diagnose this. Then the diagnostic algorithm, I have already told you that you first take detailed history, then a physical examination, and then if you have signs and symptoms of a well-defined disease, then you treat it. If there are no such symptoms, then we label her as a patient of pelvic pain syndrome. That means no findings there, but she is still having pain, okay? And then we go organ-specific, focus on organ-specific symptoms. So she will say, no, pain is in the bladder. Or she says pain is in the bowel, or pain is while she is having intercourse or something. So in those cases, we will then label her as one of the syndrome and then treat her with a focus on that syndrome, right? That is a phenotype, basically. So the phenotype could be urology, could be gynecology, could be gastroenterology, could be neurology, could be sexology, could be related to pelvic floor. So we need to identify that. So a word about vulvar and vaginal pain, although we include that in the chronic pelvic pain, but actually this is categorized separately. So this vulvar pain may be due to specific disorder. It could be infection, it could be inflammation, it could be trauma, it could be a growth, right? But, you know, there are two things. One is vulvodynia, where everything is okay, but she has pain, okay? She has pain in the vulval region. Usually it is associated with anxiety, depression disorders as well. And then it could be a focal pain on light touch on the vulvar vestibule when you touch it. So that is known as, vulvar vestibular pain. So it could be these, and these need to be addressed in a different way. So this is a cotton swab testing in localizing vulvar vestibular pain syndrome. Please understand when I say word syndrome, syndrome means it has got centralization. So we need to stop that vicious cycle to treat this patient, otherwise she's not going to get cured. So no, there are no standardized lab or imaging studies in women with chronic pelvic pain. The selection of test and imaging would be guided by the history and physical examination, right? So CBC with ESR we would do for all, because tuberculosis we feel wherever we can't explain anything, we label it on tuberculosis. So we start with that. Urine analysis, stool examination for ovacyst, screening for sexually transmitted infections, doing an ultrasound of the pelvis, including the KOB region, and then MRI. MRI is very useful, especially the pain specialist would now look at the nerve entrapment and other things, and even nerve conduction studies they do, and then of course laparoscopy, right? So laparoscopic pain mapping or pain-assisted, patient-assisted laparoscopy is experimental. I'm saying it does not actually is not been recommended as one of the methods, but of course to rule out other pathologies you can go ahead. So treatment is, you have to treat the pain, that is the symptom, and then you have to treat the disorder causing or contributing to the pain. So these are our two main things. So it has to be a holistic approach with active involvement of the patient. So you have to run a three-legged race with her, and it is based on biopsychosocial model, the SIEGE's integrated model, which I told you. You have to focus on each of the aspects, the psychological aspect, the social aspect, and of course, the biological aspect. And the management options include pharmacological and non-pharmacological and surgical interventions. So in the pharmacological, I will just take you through these are the guidelines which I have referred to. So you have these European Association Urology Guidelines 2024, and you also have ACOG Guidelines 2020, and then the SOGC Guidelines. You can always look through that. So this is the algorithm for management of chronic pelvic pain. So the patient presents with chronic pelvic pain, unknown cause of pain, or there is a known disease process. If there is a known disease process, treat the disease according to specific guidelines. If there is unknown cause of pain, then we give simple analgesia. So we start with paracetamol or non-steroidal anti-inflammatory drugs. Sometimes, they are not taking the drugs regularly. They take it only when the pain is there, then they will take it again when the pain is there. So we ask them to go on regular interval. And then if there is no relief, then we look at whether there is a cyclical component to it or there is no cyclical component. If there is cyclical component, then we definitely would try hormonal therapy. Because cyclical component would mean that probably it is related to, endometriosis or something. So we do give her a trial of hormonal therapy, right? And in case it is non-cyclical, then we go more in terms of neuropathic pain and also evaluate her for any mood disorder, right? In case we find there is mood disorder, then we would refer her to a psychiatrist. Sometimes they don't want to go to a psychiatrist. We must understand that gynecologists can prescribe. We do prescribe fluoxetine SNRIs. Okay, so that is okay. You do write a referral and at least give her a trial of 2 weeks. And it's just 20 milligram before breakfast that you can start her. And then, it kind of helps her out and then she's ready to go to a psychiatrist as well, right? And in case, the other options are that gabapentin can definitely be given for neuropathic pain. So all these other drugs. But remember, you can't treat it alone. You can't treat it alone. And regarding the adhesiolysis, it is not, if they're dense adhesions or something, then of course you can release them. But generally doing a laparoscopy can make them even worse. In case on assessment you feel there are no adhesions, everything is mobile, then don't go ahead and put in a laparoscope. We burnt our fingers because the patient's pain got aggravated after that. And when you actually do a laparoscopy, please tell her that it may not help her. It may not help her, right? And by removing the adhesions, the things can even get worse. So let her be prepared for that. So to sum it up, we all must remember that chronic pelvic pain is there, but we do not diagnose it because we are not oriented and sensitized to the fact. All involved in the management of chronic pelvic pain should be aware of a peripheral and a central pain mechanism. It is not that they are just feigning. No, they have problems, so please acknowledge it first. Women with pelvic pain should have full gynecological history and evaluation using laparoscopy. And patients with chronic pelvic pain should be screened for abuse. Domestic abuse, sexual abuse, all these things are there and we need to understand that they are there. And early assessment of chronic pelvic pain should involve investigations for specific disease-associated pain, assessment of behavioral, functional, sexual, emotional, quality of life-related issues. So all that evaluation has to go. People don't discuss their sexual history. Please make sure as gynecologists that you delve into it and help them have a good, happy sexual life, right? Then early assessment of diagnostic procedure should be adapted according to the patient, and chronic pelvic pain syndrome should be managed by a multi-specialty and multidisciplinary team addressing all symptoms. So I would suggest that every university or every medical college should have a department of chronic pelvic pain and with people from different specialties there who are interested and taking it forward. Thank you so much for patient hearing.
Thank you very much, ma'am. It was a pleasure listening to a wonderful talk on a very difficult topic called chronic pelvic pain. I, being a surgeon and a professor of surgery, we do also encounter chronic pelvic pain, both in women as well as men. Women, definitely, a larger amount of patients are going to you. Some of the patients are definitely coming to us related to the perineal region, maybe perineal syndrome, and anal conditions. Whereas in man, we are getting lots of bladder pain, prostatitis.
Absolutely.
So what I am trying to ask you, ma'am, now with this multiple concepts and multi-speciality, this term has changed. Now we are not labeling it as coccydynia or a vulvodynia or anything. Is it now probably called as chronic primary pelvic pain?
Definitely.
Or a pelvic pain syndrome? Now, these are the two different nomenclature. Where would you like to a regional pain syndrome, or you would like to call as only chronic pelvic pain? And
No.
that too, ma'am, possibly a primary or a secondary. So what we are trying to deal over here and what you have been trying is basically a primary chronic pelvic pain. The secondary could be the cause.
I fully agree with you, and you are right when I say I have not used any of the dynia's term here, right, in my talk. So basically, I said chronic pelvic pain is a symptomatology. So when I talk about it from the gynecological point of view, right? But you are right that we are not anymore labeling it as, a chronic pelvic, any of the dynias. So it is a chronic primary pelvic pain syndrome. You can call it primary pelvic pain syndrome. Is it right?
Yeah.
But when I say chronic pelvic pain, I am also including the secondary component of it.
You are including
Yeah,
the second.
I'm
But
the
then it has to be organ specific, ma'am.
Yes.
So then it has a cause. So we may not put it as a chronic primary pelvic pain.
No, you're right. I have not talked about only the primary component of it. I mean to say some patients, you have a cause. When you treat the cause, the pain persists. Are you getting me? So that falls into that category of, again, a pain syndrome. Because, say, if there's a patient who's got a fissure, the fissure gets healed, but the pain doesn't go off.
Yeah.
Is it right? So that is, again, a syndrome. And say, when he or she comes to you...
Possibly, very rightly you have said 3 to 6 months. If a pain doesn't subside
Yes.
in that period of time,
Yes.
then you might peripheral to centralization to syndrome.
Absolutely,
Specialty,
absolutely.
yeah.
So what I mean to say is the treatment may be done of that pathology may not exist anymore, is it right? But that passage of stools will provoke. You know, if you do a proctoscopy or something, maybe everything is all right, everything is healed. But still, the pain is there because whenever she passes, that thing gets triggered and the response is a hyper response.
Dr. Ruchi, can I say something? You see, I'm an orthopedic surgeon. During the last more than 7 years of my career, I have seen 2 unusual causes of pain, which probably I didn't find on your list. There was a patient in the third trimester of pregnancy, who was referred to me with the groin pain. She was limping. The hip movements were very painful. The pain was going up to the knee. And actually, we got an MRI. It proved to be avascular necrosis. And avascular necrosis of the hip associated with pregnancy is generally always on the left side. Probably the iliac vein is compressed because of the fetal position, and because of the backflow of blood, the intravascular tension causes avascular necrosis. The second relatively more common cause of pain is melalgia paresthetica. You see, when the abdomen is sagging downwards because of pregnancy, there is a nerve, lateral cutaneous nerve of the thigh, which is somewhere close to the anterior superior iliac spine, and the patient complains of a burning and tingling pain in the outer aspect of the thigh and the groin. So that can be simply treated by, you can't abort the pregnancy because this is the weight of the abdomen which is causing this. So you simply inject a small dose of triamcinolone acetate, they respond very well to the cutaneous nerve. Apart from sacroiliac pain, I think you have already mentioned, these are the 2 unusual causes of musculoskeletal pain which I have seen in orthopedic terminology.
Thank you so much for sharing that, and these are indeed good inputs.
Yeah.
But, when we talk about chronic pelvic pain, we actually say it is not pregnancy related. Yes. So that rules it out, and that is why probably it was not included. But you are right that, there are trigger points, and we have injections available on the trigger point which you can inject, and you can relieve the patient of that. Right? And of course, what you have tried to, highlight is very, very important, that, when we talk about chronic pelvic pain or pelvic pain syndrome, I keep twisting the words because it keeps changing. And we are not used to using that, as far as being a gynecologist is concerned. But I think both of us are talking the same thing, that syndrome is when there is no existing problem, but still the patient has got pain. And this syndrome can be primary, when there is nothing to begin with, or it could be secondary, when initially she had a pain, like we have a patient of endometriosis. All treated, but the pain is not gone. Is it right? So, no pathology, but the pain is still there. So, I think that is what we need to understand. And syndrome also means that the centralization of the pain has happened.
What was Dr. Gautam talking about? Do you find any difference in the height of pubic symphysis or anterior superior iliac spine in a chronic pelvic pain patients?
I have not looked at it, but we have a whole lot of patients who have pubic symphysis diastasis, and who have a lot of pain in the lower pelvis. Whenever they take turns, they say they have a lot of pain, but then it disappears once the pregnancy is over.
After the delivery, it goes, yes.
And I've also seen patients who've had fractures of the pelvis. We've been unable to diagnose them. They had a lot of pain in the pelvis and the tolerance was so much that we did not realize. But finally, we found out that she had, pathological fractures.
Yeah, that's right.
Ma'am, another question. Endometriosis largely goes to you. Patients come straight away to your OPD. At times they come to us and we refer to you. Now, what is your take in a patient and endometriosis? How do you manage pain? And if even after treating an endometriosis, if the pain doesn't subside, do you put them in chronic pain regional syndrome, or you try to do something else?
So you are right. We would, we do treat them primarily, but I think we need the help of the surgeons when it is a deeply, DIE, deeply infiltrating endometriomas are there. So large number of gynecologists would not look at them, and even the radiologists would not ultrasoundologists would not tell us about that. But until you resect that area, and you have to remove that part, and the bowel has to be repaired in that. So the surgeons definitely have a great role as far as that aspect is concerned. And of course, I've told you, once centralization happens, then we put them through the same protocol. We have to have, normally our patients keep suffering because we are also not oriented of sending them and taking help from the psychiatrist. They are actually devastated.
Okay.
Is it right? So, but that proportion of patients is quite small. But we have those patients who are absolutely crippled. Even after hysterectomy, they would still have pain.
So what is your percentage of hysterectomies in these patients?
No, we would not actually go in for hysterectomy per se if the patients are young, because it is basically the ovaries which are producing hormones and are, they are kind of giving nutrition or allowing the endometriotic patches to grow in the pelvis and on the perineum, even if the uterus is removed. Those patches would continue.
Endometriosis is a wide topic, and we'll be needing another 1 more hour to discuss this thing. And very rightly said, ma'am, centralized pain whenever it is there, and she goes into depression and anxiety. So these two things also aggravates in a long term, they aggravate the pain. So even if the primary cause is removed, the pain persists because of this reason. That is why the multidisciplinary action has to be taken, and the team has to be formed for this CPP.
And a holistic approach,
yes,
simultaneously.
Yes,
it is not that we treat one, then send her off to another one, then she again comes back.
I can see a few of the PGs from the gynae department sitting here. So a very small message to them, because I have witnessed, and my gynecologist friends also have witnessed, that when these patients are chronic pelvic pain, a female comes to a gynae OPD, I have seen that it is written after 6 months or 8 months, she becomes chronic PID. And she's been treating for chronic PID. So please, whenever a patient is complaining of chronic pelvic pain, it is not just one, this is not a synonym for CPP. So you have to be vigilant, and you have to go in for all the detailed examination, what ma'am has told right now in her lecture. It was an insightful presentation. Thank you so much, ma'am.
Thank you. Thank you so much.
Where do you keep PID, ma'am? Is this term PID?
Pelvic inflammatory disease.
Are we using these terms now?
Yes, we do use the term pelvic inflammatory disease.
Okay.
Yes, it is there.
How do we classify them?
So we have our own criteria of classifying it. There has to be signs of inflammation, there has to be induration, there has to be tenderness, So there could be fever, there could be counts which are raised. So we have a whole criteria of diagnosing PID. But generally, अगर कुछ नहीं समझ आता है तो PID. Sometimes if it is a rough examination, that also is labeled as PID. उसको tenderness मान लेते हैं. वो tenderness नहीं है. You have to be very gentle when you examine the patient.
So actually, by the time the patient comes here, she has already taken that 14 days course of PID and all. And there's a tendency, if the previous documents are not there, we keep on repeating those 14 days.
Absolutely.
Treatment. Yeah. So that multidisciplinary research is very important in these cases, that history, examination and all. And of course, as you said, first pervaginal examination and then perspicuum examination in this. Usually we do the other way around. And I just wanted to ask you, if the radiological report comes as pelvic congestion syndrome, and all the other parameters are normal, how do we approach that patient?
No, actually, that is, we do not have ample evidence to say that is a cause for PID, and we do not have any specific therapies also available. So this is all under research. So I may not be able to give you a right answer to that, but we do have some patients who, their radiologists have shown that there is congestion, but we are not sure whether you can block those vessels, do a embolization, and then kind of do it, because these are venous pools. So even any kind of embolization doesn't work. So I'm not too sure about what to do about
Well,
this.
I have a comment on this, please. Pelvic congestion syndrome is not a radiological diagnosis. Deep pelvic endometriosis is a radiological and imaging diagnosis, and as Dr. Ruchi said, pelvic inflammatory disease is also a radiological diagnosis, but congestion syndrome is not a radiological
No,
diagnosis.
even pelvic inflammatory disease should not be a radiological diagnosis.
Pelvic inflammatory disease, we do find on contrast MRI enhancing TO masses, we find pelvic peritoneal inflammation. We do have such cases.
Agreed.
Yes.
Agreed, but not on ultrasound. Ultrasound alone
No,
should not be
we are
able to
talking about
diagnose.
imaging as a whole. I'm talking about imaging
Yes,
as a whole.
I do agree with you. I do agree with you.
Ma'am, I just want to pass one take-home message. I don't know whether you would agree or not. The investigation part, the radiology and everything should be done to minimum in a patient with chronic pelvic pain.
Absolutely. I am fully on the same page as you are.
Though lab, yes.
Most of the clinicians investigate to such an extent,
No.
it becomes difficult for the patient to really...
It has to be guided by the history.
Yes,
I said take a detailed history and then guide your,
is good enough.
guide your investigations accordingly.
Yes. Though it is inconclusive, sir, the lab investigations and imaging studies are inconclusive, but we do need to get these tests done in most of the patients to rule out the comorbid conditions which can be picked up at any point. Yes, sir.
I think everyone wants us to be out of this place because they are running short of time, no? I can see some discomfort around, so. It was a topic which involved everyone, so that is why I chose this topic for this conference, yeah. All right, I hope. I have not been able to cover it completely, but whatever I could cover, I have tried to cover it, yeah. Thank you.
Thank you, ma'am. This was truly an informative and insightful session for all of us. I would now request Dean ma'am, Dr. Archana Mehta ma'am, to felicitate our distinguished speaker, Dr. Manjupuri ma'am. I would request the chairpersons to felicitate our distinguished speaker. I would now request Dean ma'am and Dr. Archana Mehta ma'am to felicitate our esteemed chairpersons. Thank you all for your valuable time. I would now request Dr. Shruti Gupta ma'am to please take the sessions forward.
Moving on with the next session for the day, that is on role of medicine in aging and neurodegenerative disorders. To chair this session, I would like to invite Dr. Poonam Narang ma'am, Dean Maulana Azad Medical College, New Delhi, Dr. Ashok Kumar Dash, Professor Department in the General Medicine, SMSR, Dr. Vijay Gupta sir, Senior Consultant Department of Nuclear Medicine, Sharda Healthcare, Greater Noida, and Dr. Soumya Mittal sir, Consultant Department of Neurology, SMSR. Please welcome them with a round of applause. I would now request our honorable chairpersons to please introduce our esteemed speaker, Dr. Madhvi Tripathi, Professor in the Department of Nuclear Medicine, AIIMS, New Delhi.
Thank you so much. It's my pleasure to invite Dr. Madhvi Tripathi, who's a professor in the Department of Nuclear Medicine in AIIMS, New Delhi. And I invite her to speak on the role of nuclear medicine in aging and neurodegenerative disorders. She is a young faculty in All India Institute of Medical Sciences, and her clinical research focus is aiming at imaging in neurodegenerative diseases, which is a very niche area of imaging, and probably the state-of-the-art imaging is being done in her department in this regard. Welcome, madam.
Thank you, chairpersons. Good morning, good afternoon to all of you. And at the outset, I would like to thank the organizers, Dr. Nirupama and Dr. Shabnam, to have me here. And today being Children's Day, I would like to wish a very happy Children's Day to all the young minds here also. And so I'll be talking to you about functional imaging, that is positron emission tomography in aging and neurodegeneration. Now, the areas where functional imaging comes into play, apart from the the most important investigation when we talk of the brain is MRI, but there are certain areas where functional neuroimaging, and especially positron emission tomography as the technology evolves, has a role to play, and that is in neurocognitive disorders, in movement disorders, more specifically Parkinsonism, in autoimmune and paraneoplastic syndromes, in brain tumors, especially recurrent high-grade gliomas, there is an evolving theranostic aspect, and in carcinoma unknown primary with brain metastasis, positron emission tomography being a whole body imaging modality. Now, the backbone of nuclear medicine, because all of you would be fresh to the word nuclear medicine. So we deal with radionuclides and radioisotopes for diagnostic and therapeutic purposes. And the backbone of nuclear medicine is our radiopharmaceuticals, which, as the name suggests, is the radionuclide, which would be a gamma emitter or a positron emitter, or a therapy radionuclide like an alpha or beta emitter, along with the pharmaceutical, which is otherwise called the radio tracer. Tracer means it traces a particular physiological or pathological process and carries the radionuclide with it, and that is the basis of imaging. So it's basically a branch of medicine like radiology where we image, but we use radionuclides. Now, if I take the first example of F18, that is fluorine 18 fluorodeoxyglucose. So as the word suggests, it is a glucose analog. And all of us know the brain is a obligate glucose user. It needs glucose every second, every minute. And if we tag fluorodeoxyglucose with a radionuclide, that is fluorine 18, which is very similar to the hydrogen molecule, we can evaluate a very important process, which is brain glucose metabolism. So when we talk of the backbone and the radiopharmaceuticals, we've got radiopharmaceuticals which can look into glucose metabolism, and the most important being F18 fluorodeoxyglucose. And the other metabolism pathways which can be traced out are the amino acid metabolism using tracers like carbon-11 methionine, fluoroethyl tyrosine, and choline. We can also look at the kynurenine metabolism in the brain in certain diseases. Now, apart from that, we've also got tracers which can bind to receptors in vivo, which can trace out the important neurotransmitter mechanisms in the brain. And the most important neurotransmitter mechanism which is evaluated using PET is the dopaminergic pathway, which we'll talk of in future. We've got tracers which can target the dopaminergic pathway. We've got tracers which can target the serotonergic pathway, the acetylcholinergic pathway, and the benzodiazepine receptors. A more interesting aspect is that we also have tracers which can go and bind to pathology in vivo. So we've got tracers which are called the biomarker tracers, which can go in vivo and bind to amyloid plaques or tau tangles and activated microglia, which can help us to look at neuroinflammation in vivo. Then a more evolving aspect is what is called theranostics, which is basically diagnostics along with therapy, wherein we treat what we see. So first we're going to use a diagnostic radiopharmaceutical to see the disease process, and then we're going to target it with a therapeutic radiopharmaceutical, which would be an alpha or a beta emitter, and use it for therapy, which is called theranostics. And two of the important pathways which can be imaged as well as treated are the somatostatin receptor expression in the brain, which can be done for meningiomas, and the prostate-specific membrane antigen, which can be done for recurrent high-grade gliomas and their therapy. So then moving on to the major neurocognitive disorders, and the most common of them, which all of us know under the broad term dementia, which is an umbrella term which is used to describe a range of symptoms associated with cognitive impairment. The most common cognitive impairment being Alzheimer's disease dementia, the others being dementia Lewy bodies and frontotemporal dementia, and of course vascular dementia, which is an overlap in many syndromes and is more appropriately diagnosed using MRI. So the pathology in Alzheimer's disease, as all of us know, is the deposition of Alzheimer's, is the deposition of intercellular amyloid plaques and intracellular tau tangles. Now, the National Institute on Aging and Alzheimer's Association research framework have defined Alzheimer's disease by its underlying pathological processes, which can be documented by post-mortem examination or by biomarkers in vivo. And therefore, this shifts the definition of Alzheimer's from a syndromal entity that is based on its signs and symptoms to a biological construct. Therefore, which is called the ATN classification of disease, or where A stands for amyloid beta, T for tau, and N for neurodegeneration. So if you want to call a patient Alzheimer's now, you have to show the presence of amyloid. And this can be shown by the amyloid in vivo. So to call the patient to have Alzheimer's pathology, the presence of amyloid is a must, with or without the presence of tau tangles and neurodegeneration. Whereas, if you do not have amyloid, then the patient is most likely a non-Alzheimer's pathological change. Therefore, to define Alzheimer's in vivo, we can use biomarkers. Now, what are the biomarkers we can use? For amyloid beta protein deposition, all of us know these are proteins which normally also they are present, but their abnormal accumulation is what leads to neurodegeneration, which is a progressive process. And why do we need to define it? Because it helps us to prognosticate the patient, it helps us to treat the patients. Now with therapies available, all of us know we have anti-amyloid therapies which have now been FDA approved also. We need to say that there is amyloid in the brain to treat it. So the biomarkers which we can use is a demonstration of amyloid in the CSF or amyloid imaging using the amyloid imaging agents as I showed you. Or you can document downstream neuronal degeneration and neuronal injury using CSF tau or F18 fluorodeoxyglucose PET or tau PET, as well as magnetic resonance imaging, which would show you the atrophy. So this is to show you a normal fluorodeoxyglucose PET scan. The uptake is in the normal gray matter, as well as the subcortical gray matter, which are the basal ganglia and thalami. So you can see that the normal scan would show you the uptake in the gray matter cortices and the subcortical gray matter, which is the basal ganglia and thalami. Now, moving on to what do we see in Alzheimer's disease. So what do we find? Like you saw in the previous scan, you saw this was the uptake in the temporoparietal cortices, whereas here you can clearly see, as compared to the uptake in the frontal lobes, the parietal lobes show a decrease, as well as the precuneus and posterior cingulate and the temporal lobes, which show a decrease in glucose metabolism, which basically means that there is a neuronal downregulation there is a neuronal injury there is a synaptic dysfunction over there, and this temporoparietal and precuneus posterior cingulate hypometabolism, along with preservation of metabolism in the sensory motor cortices in the basal ganglia and thalami in the cerebellar hemispheres, this would be called the metabolic signature of Alzheimer's disease. So if we can get to identify these metabolic signatures, we can tell you that this is probably a patient who has Alzheimer's disease. So this is basically defining Alzheimer's in vivo. And it's not only visual analysis, we can also use robust voxel-based statistical techniques like statistical parametric mapping, where they clearly delineate the temporoparietal hypometabolism along with the precuneus and posterior cingulate hypometabolism. As against frontotemporal dementia, which is another dementia which has to be differentiated from Alzheimer's disease. It is an FDA-approved indication. FDG PET is used to differentiate Alzheimer's from frontotemporal dementia. So as against the parietal cortices, you can clearly see that the frontal cortices and the temporal cortices are more hypometabolic, and this is the signature pattern for frontotemporal dementia. This can again be, you can use techniques like 3D stereotactic surface projection maps and voxel-based techniques to show the frontal hypometabolism and classify this patient as having FTD. The other dementia which would need distinction would be the diffuse Lewy body dementias, where you have Lewy bodies depositions in the brain. And here the classical pattern is a hypometabolism in the visual cortices with preservation of metabolism in the posterior cingulate, which was down in Alzheimer's disease. Along with dopaminergic dysfunction, this patient could be called a dementia with Lewy bodies. And these, basically these patterns and these metabolic patterns as well as these neuroreceptor patterns have been used into the diagnostic criteria for these diseases. As can be seen that dopaminergic imaging can be used as an indicative biomarker, and FDG PET can be used as a supportive biomarker for the diagnosis of dementia with Lewy bodies. So apart from MRI, you have something in your armamentarium which can help you define these diseases, act as biomarkers in vivo. Moving on to mild cognitive impairment, as the name suggests, it is a mild cognitive impairment, not severe enough to be called dementia, but it is important because you need to tell which of these patients would progress to Alzheimer's disease dementia and which of these patients could be included into trials for anti-amyloid therapy. Now here again, to classify that the mild cognitive impairment is due to Alzheimer's disease, high likelihood, you need to have amyloid beta positivity. So if the patient tests positive for amyloid beta, either by imaging or CSF, along with a positivity of neuronal injury markers like FDG and tau, you can say this patient has MCI with a high probability of, high likelihood of it being due to Alzheimer's disease. Versus those patients who would be amyloid negative, and these patients can be said to have MCI unlikely due to AD. Okay, so this is how it can be used for classifying patients with mild cognitive impairment. You can see an example. This is a patient with mild cognitive impairment, query AD, a very early parietal and temporal hypometabolism on FDG PET, which would suggest that this patient is MCI, intermediate likelihood for AD, because I do not have amyloid PET. And similarly, when you do another patient, a 58-year female with anxiety, forgetfulness, now the question is whether it's AD and a mild cognitive impairment, whether it's AD or FTD. Clearly you can see the hypometabolism is more marked in the frontal cortices and the temporal cortices. This would be MCI unlikely due to AD but likely due to FTD, frontotemporal dementia. So as far as the biomarkers, as I told you, we do not have amyloid PET in India so far. We are trying hard to get the amyloid agent. So we need to get these agents, we need to tag them with the radionuclide, we need to use them in patients. So far we've used fluorodeoxyglucose and we've used tau PET. Now the beauty of tau PET is that it is like an inverse proportion to FDG, as I told you. There is a parieto-temporal hypometabolism, including the precuneus and posterior cingulate. And in exactly these hypometabolic cortices, you would find a tau deposition. So while you find hypometabolism on PET, you have abnormal tau accumulation in the similar cortices, which is inversely proportional to the cognitive impairment of the patient. So the more the cognitive impairment, the more the hypometabolism on FDG, the more the tau PET deposition, which you would find in the cortices. Similarly, I've just put in the cortex ID maps to show you very clearly. The above two rows are the FDG, and these are the tau PETs of the patients, clearly showing you the 3D distribution of hypometabolism in the parieto-temporal cortices, along with tau deposition in the similar cortices. In early AD, again, a hypometabolism in bilateral parieto-temporal cortices with tau deposition in the parieto-temporal cortices, versus advanced Alzheimer's disease dementia, where you have parieto-temporal as well as prefrontal hypometabolism and a tau deposition in a more widespread distribution, spatial distribution pattern, versus non-ED or FTD, where you have tau in the frontal cortices but not distributed in the parieto-temporal and posterior cingulate. So as I told you, as in now, we have an agent which is called lecanemab, which is approved. It's an anti-amyloid agent which can actually wash off the amyloid plaques. So if you have an imaging which can show you the plaques, if you have an imaging which can show you, so this is a literature example of amyloid positivity, and if you have imaging which can show you the amyloid, followed by therapy, you can show a washout of amyloid. So you can actually improve on the power of the study, you can improve the output of a clinical trial by having imaging which can be biomarker based. So therefore, summing it up, the indications of metabolic imaging and using metabolic signature patterns in cognitive impairment would be as biomarkers, amyloid, tau PET and FDG PET, or to evaluate response to therapies for a differential diagnosis of dementia subtypes, as I showed you, and for evaluation of mild cognitive impairment. Now moving on to another neurodegeneration, which is Parkinsonism, which is, as you all must have read, a classical triad of tremors, rigidity and bradykinesia with or without postural imbalance, the most common etiology of which is idiopathic Parkinson's disease. Now this, not all tremors, rigidity, bradykinesia would be IPD, and early in the disease course, that is less than 2 years into onset, it would be important to distinguish this from other causes of tremors, which could be drug-induced, which could be vascular Parkinson's, which could be psychogenic Parkinson, and then another important entity which we have to distinguish from IPD, that is the Parkinson plus syndromes. Now, the targets for dopaminergic imaging would be the presynaptic terminal, where one of the most important target is the dopamine transporter, which you would have read, transports the dopamine from the synaptic cleft into the presynaptic nerve terminal for storage. The body wants to conserve as much as it can. And this DAT transporter can be targeted using SPECT and PET agents, which can bind to the dopamine transporter. So to pick up early idiopathic Parkinson's disease, and for a diagnosis of dopamine deficient Parkinsonism, which would differentiate neurodegenerative Parkinsonism from non-neurodegenerative forms of Parkinsonism, which would definitely have a better prognosis, we can use dopaminergic imaging, and also to differentiate it from, as I told you, essential tremors, vascular, psychogenic and drug-induced Parkinsonism. If you have neurorestorative therapies like stem cell therapy or embryonic stem cell transplantation, you can assess responses to therapy using dopaminergic imaging. Again, as and when you have trials for washing out alpha-synuclein, which is a pathology in IPD, for entry into clinical trials, dopaminergic imaging is important. In fact, for all the clinical trials for Parkinson's disease, dopaminergic imaging is an integral part. For differential diagnosis of subtypes, you can use D2 receptor imaging, which is on the postsynaptic terminal. And also for DLB, as I showed you, dopaminergic imaging is a indicative biomarker. So what do the images look like when you're doing that imaging? You can see two commas in the brain, which are actually the basal ganglia. You can see the uptake in the brain, which is called this is what is seen in a normal study, C2 commas. Now what happens in IPD, early IPD, there is a loss of the comma, it becomes a full stop sign, and there is a loss of activity in the putaminal regions, which signifies a presynaptic dopaminergic dysfunction. And this is a patient with early IPD and would have symptoms on the opposite side. So this patient would have tremors which are predominantly on the left side and be more symptomatic on the left side. So this is a modality which can show you dopaminergic deficit in vivo. Now moving on to the atypical Parkinsonian syndromes, as I told you, there is a group of Parkinsonian syndromes which are called atypical, which includes progressive supranuclear palsy, multisystem atrophy, and corticobasal syndrome. Now, why do we need to distinguish them from IPD? They're all forms of Parkinsonism, but the atypical Parkinsonians have a poorer prognosis associated with them. These patients usually progress fast. They would not respond to syndopa, which is the classical form of therapy in IPD. And deep brain stimulation would be ineffective in these patients, and these patients should not be included into clinical trials for IPD. So therefore, you need to distinguish these subtypes from IPD, and again here the metabolic signature patterns on FDG PET would be something which we look into. So as in a case of IPD, you can see on dopaminergic imaging, you have 2 full stops, which basically means that there is advanced Parkinson's disease. But on the FDG PET, you can see that the basal ganglia are showing more or less normal uptake, or there is more of hypermetabolism, which can also be demonstrated on the statistical parametric mapping. So a pallidothalamic hypermetabolism along with parieto-occipital hypometabolism, this is what is called the Parkinson's disease relative pattern or the metabolic signature for IPD. Whereas in Parkinson plus, like multisystem atrophy, cerebellar type or the mixed type, you can see that clearly the basal ganglia are showing a decrease in the FDG uptake. Compare it with the thalamus, you can clearly see that the basal ganglia are hypometabolic, whereas the DAT imaging or the dopaminergic imaging continues to show you 2 full stops. So while DAT imaging cannot differentiate between the two, it is the FDG PET metabolic signatures or the related patterns which can tell you this is a patient with Parkinson plus syndromes. Similarly, you can do statistical parametric mapping and demonstrate these patterns. In a patient with progressive supranuclear palsy, again, see, what is most important is the clinical, what the clinician is going to see and tell you. But these are modalities which are going to help the clinician to further classify his patients. So in a patient with progressive supranuclear palsy, he would be presenting with backward falls, gait impairment, ophthalmoplegia. If you have an FDG PET pattern which is showing you hypometabolism in the basal ganglia and in the midbrain, along with a dopaminergic imaging which is again showing you 2 full stops, this pattern would be suggestive of progressive supranuclear palsy and would help in diagnosis of an atypical Parkinsonian syndrome. Similarly, in corticobasal syndrome, again dopaminergic imaging, while it will show you the 2 full stops and suggest dopaminergic deficit, the FDG PET pattern showing you cortical as well as subcortical or basal ganglia hypometabolism is classical for corticobasal syndromes. So this is how metabolic signature patterns help us in neurocognitive impairment, in Parkinsonism. You've seen these metabolic patterns are which help us identify that this would probably be this syndrome. Now moving on to another very much now it's become a really common entity, which is the autoimmune and paraneoplastic syndromes. Now this is an immune mediated response which develops with the presence of antibodies which target the neuronal cell surface antigens or the intracellular antigens. And what happens when the body mounts this response, the patients present with various neurological syndromes. What becomes important to identify is it warrants a search for an underlying cancer, because if there is a cancer, and treatment of the cancer would be what is expected for best clinical outcomes. So when we are talking of clinicians, when we are talking of clinics, what we want is good patient outcomes, and that can be achieved by an accurate clinical diagnosis and a timely clinical diagnosis. And that's where the imaging armamentarium is going to help the clinicians. So what you need to search is the various malignancies which can present with neurological syndromes because of the antibody mediation, and that's where fluorodeoxyglucose PET, again being a whole body imaging modality. So once we inject the fluorodeoxyglucose, it goes into the body. So not only can you image the brain, you can also do a whole body imaging, and you can look at the thorax, you can look at the abdomen, you can look wherever there is a primary or its metastasis, you can actually do a one-stop staging of the whole body. Just as an example, a 50-year male with subacute symmetrical distal to proximal sensory motor polyneuropathy, CIDP versus paraneoplastic syndrome, sent for FDG PET, you can see that he has a retroperitoneal and pelvic lymphadenopathy, biopsy of which revealed lymphoma. So this is how the whole body PET, so this is the brain, this is the whole body. You can see there is a normal distribution of FDG in the whole body. and there is excretion of the FDG via the urine. So fluorodeoxyglucose is a glucose mimic. It is taken up into the cells via the GLUT transporters, which transport glucose into the cell. It undergoes phosphorylation to glucose 6-phosphate, like you've read in biochemistry, but following that, it does not undergo any further metabolism, and it becomes metabolically trapped inside the cell, which is called metabolic trapping, and this is the imaging we get out of it. So we're just mimicking a simple molecule like glucose. Similarly, a patient presenting with paraneoplastic cerebellar degeneration, which is actually due to a small cell lung cancer, right lung, and not only the primary cancer, you can see he has diffuse metastasis in the skeleton also. Moving on with entity which is called carcinoma unknown primary. So the patient presents with multiple lesions on MRI. The neurosurgeon is very concerned that could it be a brain metastasis, and then he advises an FDG PET brain for these multiple lesions in the brain, and you can see, lo and behold, you have a carcinoma in the right lung. So you can see that this is a primary and probably a metastatic nodule in the same lung. So this patient is actually a lung carcinoma who has presented with brain metastasis. So that is how FDG PET can help in this syndrome also. Finally, ending with an evolving aspect, that is the theranostic aspect, where I told you that we have tracers which can be diagnostic, like gallium-68 tracers, and that can be followed by therapy with beta-emitting lutetium or alpha-emitting actinium-225. You can see there are a number of targets which are expressed in the CNS, and these can be used. One of the examples I'll be showing you, which is gallium-68, prostate-specific membrane antigen. Now, this molecule can not only be used for prostate cancer staging and therapy, it can also be used for neovasculature has expression of PSMA. Imaging this expression of PSMA can make it a target for therapy. As you can see in this patient with multifocal recurrence of GBM, gallium-68 PSMA is showing multifocal expression, and this can also be targeted and used for treatment of this patient with a recurrent GBM in the left temporal lobe. So in conclusion, metabolic signatures on FDG PET can be specific for dementia subtypes and atypical Parkinsonian syndromes, along with autoimmune encephalitis. I haven't shown you much about this work. Now, this is where we identified there are signature patterns, which are basically a basal ganglia hypermetabolism with a mesial temporal hypermetabolism, as well as cortical hypometabolism, which can be used to identify autoimmune encephalitis like NMDA receptor encephalitis and LGI1 encephalitis. Dopaminergic imaging provides in vivo evidence of presynaptic dopaminergic deficit. FDG PET-CT as a whole body imaging modality is extremely useful to look for malignancies and has a high negative predictive value in the setting of paraneoplastic syndrome. So if you say that there is no malignancy detected, the neurologist can be sort of sure that, okay, let's go ahead with the other options we have. And its theranostic potential in high-grade gliomas is being explored. Thank you.
Thank you, ma'am. It was a beautiful presentation, beginning with certain basics, which is not clearly understood by most of our clinicians, because the things have not yet been included in the curriculum of NMC and all. And this is a beautiful imaging procedure, unlike CT and MRI, which due to certain limitation cannot do whole body. And this whole body imaging can pick up so many elusive diagnosis, which the clinician feel quite happy to treat the patient in one go. So that way it contributes in another area we discussed yesterday also, fever of unknown origin.
Yeah, exactly.
Which can come into brain, which can present as some brain abscess, and we have treated certain BVIPs during our exposure in the past. So this thing can be extremely helpful.
Yeah,
so
because
ma'am has done a great justice. We didn't have to tell her the timing about perfectly in time she has finished. She has been a colleague of mine for last 2 decades.
Thank you.
And she looks young, but she is very, very two decades plus experience in All India Institute after tenure in Mass and all. So we can, due to paucity of time, we can invite a couple of questions only. Thank you.
Yeah, I would just like to add, it's a very sensitive modality. So not only does it pick the malignancies, it also picks infection, which is very important in pyrexia of unknown origin, but it is, the specificity is lacking. So we've added on with FDG PET-guided biopsies, which are called metabolic biopsies. So you can actually biopsy the metabolically active area and tell what it is. So that's another addition in... yeah.
So, a small query. Right now, the bulk of diagnosis of neurodegenerative disorders rests on clinical evaluation and MRI.
Yes, ma'am.
Which patients would you flag for sending to for PET imaging? For a clinician, which ones should they, choose from the bulk?
Yeah, ma'am. So as you said, the clinical presentation would be the one which the neurologist uses to say what type of dementia or Parkinsonism he's looking at. But when these patients are very early into presentation, that is less than 2 years into the disease, where the disease is still evolving, and where there may be a certain overlap, like a patient with Alzheimer's may present with behavioral abnormality, and the neurologist will be concerned is, am I looking at FTD, am I looking at AD? That's where he would send it to us. Or a patient with Parkinsonism would have certain red flags, like he would have too many of autonomic symptoms, or no response to levodopa. That's where, again, they would send for dopaminergic imaging to confirm that their diagnosis is consistent with what probably we would be looking at in imaging.
So you think it is only for early diagnosis?
Mostly
or
early
is it
diagnosis.
for further classifying the subtype?
It would be for classifying
that would
subtypes
be more,
also.
appropriate, I guess.
But ma'am, everything would be early on, because when the patient evolves over 4 years, there again the clinician, because he'd already a PSP patient, would be on the bed by 4 to 6 years. So again, the neurologist is pretty certain that, okay, this is a atypical Parkinsonism. He would not. It's only in the early course, and of course the neurologist would be in more, aptly ascertain what.
I would agree with sir that this was a beautiful presentation. I hope our students have been able to pick up something, because this was nothing can
Dr.
be made more
Das?
simple than this. Absolutely brilliant.
Want to ask a question?
Thank you.
Can I ask a question? See, though the question is not related to neurodegenerative diseases of the spine, but since this is a new topic,
Sir.
and I'm an orthopedic surgeon, I just want to understand, now since there are different radionuclides, just as immunohistochemistry has helped a pathologist to almost reach like a biopsy diagnosis, how close we are when we can match a biopsy diagnosis with the nuclear medicine techniques like this? How close we are?
That's a very good question, actually. And as I told you, it's not only the glucose metabolism, and because of the beauty of the radionuclides, we're using F18, oxygen, carbon-11, we can tag them to pharmaceuticals. So the closest we've got is, we can look at choline, which is phosphatidyl-choline in the cell membrane. So we can look at cell membrane metabolism. We can look at somatostatin receptor expression. So basically, you all know that neuroendocrine tumors have somatostatin receptor expression. So if you have a intrabronchial mass in the lung, now the endocrinologist wants to be certain that this is a carcinoid. You can just do somatostatin receptor expression, and we can actually tell you that, yes, this is a carcinoid.
So biopsy is not required in that case?
No, sir, again, to go ahead with treatment, I guess the medical oncologist would require the biopsy. That is...
So at this stage, it is we are competing with the biopsy and trying to come closer to biopsy.
Yeah.
In this stage of evolution of the nuclear.
Yeah, non-invasively come closest to the biopsy, but when it comes to therapy with chemotherapy and the toxic agents, naturally you would want... Yeah.
Sir,
Yes.
If I make a comment on that, for neurodegenerative disorders, the therapeutic options right now are very few. And brain biopsy, which we take, is not going to be a very lucid option for patients, where we cannot really offer a very good treatment. So if we have something where we can avoid a biopsy which is more invasive, if we can get an idea on the patient's diagnosis and we can treat the patient there, so that would always be a better option. And I think nuclear medicine is already giving us those kind of answers, where we have a diagnosis and where the biopsy, till we have better options for treatment, can be avoided for now. So I think brain biopsy would not be making sense when we don't have a very good option for treatment.
Dr. Soumya, I just have one query. Madam, can you extend these services to the pediatric services also? Because we have got so many children with cerebral palsy, neurodegeneration, delayed milestones. Can your nuclear medicine can
Drug
advance?
refractory epilepsy, that would be one area. Drug refractory epilepsy, which are refractory to treatment. That's one big area where we're doing interictal PET in all these patients to identify the epileptogenic zone, and of course, concurrence in modalities, which is being used to go ahead with treatment in these patients. We are also doing it in a number of places where the pediatric neurologist, like he wants to give some form of TMS, and he wants to identify the hypometabolic area because he says that targeting that TMS to that particular area would be the best. In pediatrics, now it is used for routine staging of LCH, lymphoma, osteosarcoma, Ewing sarcoma, PNET. It's a one-stage modality which actually is very certain in staging these patients as well as evaluation of response and for surveillance.
My context is a little different, basically because of this delayed development, neuroregression, all those cases.
So that's where MRI would be the modality.
MRI, at times we get MRI here. Most of the time it comes out to be without much positivity.
SSP also some amount of these metabolic patterns.
I think that beautiful lecture. Thank you very much, and thank you for sparing time to come here. I wanted to address the issue which Dr. Thapar is talking about. Most of the neurodevelopmental delays, they are genetic disorders. So we will not be able to address these on MRI because MRI findings can be general and non-specific and look similar in a lot of them. And I think a greater expert on neuro is Dr. Poonam Narang. She can confirm what I'm saying is right, that most of these would require actually a genetic study yes, more than the MRI findings. So that is the answer to your question, sir.
I don't think there are any more questions. Thank you. Thank you, ma'am.
We thank you, ma'am, for a brainstorming and an intriguing session. I would request our chairpersons, along with Dean ma'am and Dr. Shabnam Madari Grove ma'am, to please felicitate our esteemed speaker with a token of gratitude. I would also request Dean ma'am and Dr. Shabnam ma'am to please felicitate our respected Dr. Poonam Narang ma'am, Dean Maulana Azad Medical College, with a token of gratitude. I would now request Dean ma'am and Dr. Shabnam ma'am to please felicitate our chairpersons. Next session for the day is on stroke and its neurointervention. To chair this session, I would like to invite Dr. Poonam Narang Ma'am, Dean Maulana Azad Medical College, Dr. Amita Malik, Professor and HOD Department of Pathology, VMMC and Safdarjung Hospital, Dr. Ravindra Srivastav, Senior Consultant, Department of Neurosurgery, Sharda Care, Dr. Khemendra Kumar Sir, Associate Professor, Radiology, Sharda Care. Please welcome them with a round of applause. I would request our honorable chairpersons to please introduce the praiseworthy speaker for the session, Dr. Chirag Jain. Sir is an associate professor, neurointervention at VMMC and Safdarjung Hospital, Delhi.
Good afternoon all. It's my pleasure to welcome Dr. Chirag Jain, who is faculty in our department, VMMC and Safdarjung Hospital, and he has been very actively involved in stroke management in the hospital and running the stroke unit. He has many awards and achievements to his credit, these being 30 indexed publications. He has 5 book chapters, and he has taken several lectures at various national and international forums, and he is also an executive member of Indian Society of Neuroradiology. As we know that stroke is something where early intervention really gives you good results, and the technique and the time of management, they are really changing and evolving. So it is very important that we keep ourselves updated with what is happening in the stroke management. Over to Dr. Chirag.
Yeah. Thank you, ma'am, for the kind invitation. And at the outset, I'd like to thank Professor Shabnam and the organizing committee for having me here to deliver the lecture on stroke, which is a very important emergency disease which we need to understand and know how to manage, how to diagnose these patients who routinely present, because stroke is the second most common cause of mortality worldwide after cardiovascular diseases, and the impact and the burden of the disease is significant. So at the outset, I'd like to say that I have no disclosures. Sorry, the presentation is not running. Just give me a minute. You can copy it. So ischemic stroke is basically whenever there is loss of blood supply to the brain, there is area of damage that starts ensuing within the brain, and eventually there is the damage keeps on progressing over time, leads to a lot of damage to the synapses, the neurons. Patients have paralysis, and there is a lot of mass effect which gradually ensues upon over the days or intervening weeks. And then patients can have mass effects, herniations, and can lead to probably a lot of mortality. Even if there is no mortality, patients have a lot of morbidity in terms of the caregivers who also face a lot of financial constraints in taking care of these patients is very difficult. They undergo tracheostomy, they are long-term bedridden. So we need to basically identify those patients so that we can decrease the mortality and the morbidity of these patients. ये वाली पिंक ये निकाल लो. So here a lot of time was lost. So that's what we need to identify in the emergency sitting, that a lot of patients we can miss, and those patients we need to identify so that we save those neurons and the damage. So I'll be covering, basically stroke is either hemorrhagic or ischemic, but here we are talking about ischemic strokes. And earlier there was a concept that time is brain, but now every patient has a different clock. Every brain functions in a different way. In elderly patients, there might be brain tissue which can go on to progress to damage slowly, but in few patients it can go on to progress really fast. So now the concept is tissue is brain, and every minute we see 1.9 million neurons are lost. And the definition of infarct is that the area of brain which is permanently damaged, there is complete loss of perfusion. Whereas in ischemic area is something where is just a decreased volume of perfusion. However, the sum of the viability is still present. So cerebral blood flow, we need to understand the physiology first. Whenever there is a tissue damage, the normal CBF is 50 to 100. But when there is a reduction of the cerebral blood flow to 20 milliliters of per 100 grams of tissue per minute, then there is a damage starts occurring to the brain, but it's potentially reversible. When it falls below the level of 20, there is damage to the sodium-potassium pumps, and then that's the area where infarcted tissue starts forming. What happens is that there is failure of the ATP pumps, the sodium-potassium pump, and there is accumulation of glutamate outside the cells, and there is NMDA mediated calcium influx into the cells, and potassium remains outside the cells. This leads to cell death, and eventually whenever there is cell death, there is progression and ingestion by the macrophages, which lead to accumulation of lot of macrophages and iron accumulation within these cells, which we see as hypointensity or on susceptibility weighted images. So basically the brain, it's our friend if we consider there are a lot of collaterals, and the ACA, the anterior cerebral artery, the posterior cerebral artery, the middle cerebral artery, they work in harmony. Whenever there is an occlusion of one of the vessel, there is takeover by the other vessels, which we call as the collaterals. So there are different types of collaterals, the extracranial from the external carotid artery, the leptomeningeal collaterals, these are secondary collaterals, and the pial collaterals, the direct collaterals from the ACA and the PCA, if there is an MC occlusion, are the direct collaterals within the brain. But whenever these collaterals are not there, there is loss of tissue, the extent of damage progresses very quickly. So our goals of imaging rely on, the first step is to exclude an intracranial hemorrhage, exclude the common stroke mimics like hypoglycemia or other tumors, etc. Identify the location and the extent of infarction, the parenchyma, the tissue. Identify the level of occlusion where the vessel is occluded, that's the pipes, and determine the potential treatment, whether it's a thrombolysis or a mechanical thrombectomy, for which we need to see the perfusion and the penumbra, that is the salvageable amount of tissue within the brain. So whenever a patient presents to us in the emergency department, he typically has the symptoms of facial deviation, weakness of arms and the limbs, and slurring of speech, and time is brain, so which we call it as a acronym, the FAST. And whenever the patient comes to the emergency, we do a brief, quick neurological examination, and there's a specific scale which is called as the National Institute of Health Stroke Severity Index, which all of us must be conversant upon. The anesthetist or the emergency team, the nursing staff, the stroke paramedical staff, as well as the radiologists, neurologists, who assess this scale and give us the severity of the stroke. So if it's more than 6, it's generally a large vessel occlusion. Less than 6 score means a medium vessel or a distal vessel occlusion. And we can get certified online. It's a 1-year certification validity. And the guidelines say that the use of the stroke severity index, the NIHS, is recommended. It's a class 1 recommendation. So after the the examination is done, which is very quick, it can be done in the ambulance as well. The patient is shifted directly to the NCCT, the CT scan is done, a non-contrast CT, which is fast, quick and reliable. It is the first line imaging, and the main purpose of doing an NCCT is to rule out a hemorrhage. So in a stroke suspect patient who is having a score of NIHS more than 6, then the patient can, and he doesn't have a hemorrhage, patient can be thrombolized on the CT table. And the images are, all the patients, the guidelines say that all the patients admitted to the hospital with suspected stroke should receive NCCT that will provide the necessary information to make the decisions in acute management. And we see the CT imaging on a particular window length and window width, that is 30 and 30. And what we see is the hyperdense thrombus. As you can see on this CT scan, on the left side, there is a hyperdense MCA, which is a linear hyperdensity, which is also called as the dense MCA. The MCA dot sign can be seen, and it generally signifies an RBC-rich clot, which is easily friable. It can be taken out by thrombolysis, it can dissolve by thrombolysis, and can be taken out by mechanical thrombectomy. Sometimes it may be due to calcification of the thrombus. It can be also be seen in the basilar artery. It's not only specific for the MCA, you can see it in the ACA, the basilar artery. And it's a specific sign, but although not sensitive, because some people might miss it on the console. But you have to have the eyes to look for the thrombus. So next is, after the area of damage starts ensuing, there is loss of cerebral tissue, there is edema, swelling starts ensuing, and there is loss of gray white matter differentiation. So this window width and window length helps us to see the area which leads to loss of sulcal spaces, the edema. Here you can see the damage to the lentiform nucleus. There is slight hypodensity in the MCA territory. And then there is sulcal effacement, and eventually there is parenchymal hypodensity. So this is an example of a calcified thrombus with a high attenuation value close to 100 on 150 on the right MCA and the right Sylvian fissure. And for discussing and treatment protocols, we do an aspect scoring, the Alberta Stroke Program Early CT score, which says that we include 10 areas of the brain: the caudate nucleus, the internal capsule, the lentiform nucleus, the 3 territories of the MCA in the same section, and one section above we see 3 different territories of the MCA. If the cortex, basically we are looking at the gray matter areas, if these areas are lost, we subtract a score of 1 for each area. So total score of 10 is there, that's the best score, but a score of more than 6 is taken good for considering any form of intervention. So basically a stroke which is having aspects of less than 6, that's a large MCA infarction, and patients have high hemorrhagic rate. So here's an example. You can see a left-sided dense MCA sign, and there is a hypodensity involving the external capsule, the part of one of the location of the MCA. So I would give it an aspect score of probably 8, which is a good sign. So similarly, for the anterior circulation, we have a posterior circulation aspect scoring. That is 1 point each for the thalamus, 1 point each for the occipital lobes, 2 points for the midbrain, 2 points for the pons, and 1 point for each of the cerebellar hemisphere. So PC aspects, posterior circulation aspect score of more than 5 is generally considered good for an endovascular or a thrombolysis intervention. So the findings, what we see on the NCCT scan, depend upon the time from the onset of the ictus to the time of imaging. And by ictus, I mean never ask the patient or the relatives that when the patient is having the problem from. We should ask when he was last seen well, because maybe the patient slept at 11 a.m. and since the morning the relatives have seen that patient is having the deficit, but the time is counted from 11 p.m. from the yesterday night. That's called as the last known well time. The severity of the symptoms will change. Definitely we'll see a poor CT scan, and the location of ischemia. So these are different stroke territories based on the collateral score. Sometimes we can see internal watershed infarcts, which we generally see in ICA stenosis, internal watershed infarcts, or it can be external watershed infarcts. These signify a large vessel occlusion, the embolic phenomena that occurs from the ICA. And these are watershed zones between the ACMCA and the MCA-PCA. And after the patient receives thrombolysis within the CT suite, we should do a CT angiography to detect whether there is a large vessel occlusion or not. So it is used to plan the treatment. We should include the arch, the neck vessels to see the carotid occlusion, the cause of the stroke like dissection, vasculitis, atypical cryptogenic strokes. And the guidelines suggest that intracranial vascular study is recommended, but should not delay the administration of thrombolysis if patient is presenting less than 4.5 hours from symptom onset. Also, it is very important to know that CT angiography should be done without obtaining a serum creatinine. We should not wait for obtaining a RFT report. We have to directly proceed with the angiography because the brain is above the kidneys. So these are the methods how we can take the CT angiography. We place a ROI within the aorta, the arch of aorta, and by the bolus tracking technique, we inject 4.4 to 5 ml of contrast, a 60 ml contrast, followed by 20 ml of saline chase. These are the technical things. And after that, you select a HU. Generally, it's 120 to 150 Hounsfield units. And we put a trigger on the aorta, and then we acquire from the arch to the vertex of the skull and acquire the peak of the contrast enhancement within the vessels. So wherever there is a occlusion, we can see thrombus lying there or a sudden cutoff of the vessels. Here, this is one case where you can see that in the carotid artery, there is a intraluminal thrombus which is lying within the cervical ICA. This is one example where you can see the right side MCA is completely filling, but there is a sudden cutoff of the left M1 MCA in the mid segment. And here there is a distal M1 occlusion. There is a small clot fragment located within the distal MCA. So we can also count the vessels which are involved, the occlusion of the vessels, and there's a clot burden score. The higher the clot burden score, basically the patient will have poor prognosis because there is a large amount of clot. So for each M1 MCA, for M1 MCA we give a score of 2, the M2 we give a score of 1 each, and the A1 ACA the 1 score, supraclinoid ICA 2 score, and ICA we give, infraclinoid ICA we give score of 1. And we can also see the clot permeability index, the enhancement of the clot. If we see the clot, there is a clot enhancement, that means the clot is more permeable. And if it is more permeable, that means it is more responsive to either thrombolysis or mechanical thrombectomy. It can be lysed easily. So it's a good sign to see on CT angiography. However, once the NCCT is done and CT angio is done, the LVO is detected and patient is presenting within a 6-hour window period, we should proceed with the mechanical thrombectomy. CT angiography is also being used to detect the areas of ischemia. If we are not able to do the aspect scoring, the CT angiography sometimes tells us the area of infarction that is going to progress, but it is not so reliable because it tends to overestimate the area. On CT angiography, we can also see the collaterals. We can do a multi-phase CT angiography, again, to see whether the brain parenchyma is temporarily supplied by those collaterals or not. So multiphasic CT angiography, the arterial and the early arterial and the venous phases we capture. And we see how much area of the MCA territory is filling via the different collaterals of the brain. So if 100% collaterals are there, it's a good thing, 50 to 99%, and then less than 50%. And the more collaterals are there, that means the brain is going to be preserved for some time. The brain tissue is being supplied by the collaterals, but we need to intervene early. So it's a good sign, but the collaterals, mind you, will definitely fail at some point of time. It's a good for intervention. Further, after patients who are presenting late in the window period beyond 6 hours, what we need to know is that how much area is salvageable. And for that, we need to do a CT perfusion. And we repeat the contrast study, just like previous images you were saying seeing the FDG PET. Similar to that, we are doing CT perfusion scan to determine the time since onset, plan the treatment and the salvageable area, and to tell the patient the further prognosis which is going to affect the life of the patient. So for patients within 6 to 24 hours from symptom onset, either CT perfusion or MR perfusion is mandatory. And this is the mode of acquisition. So 4 centimeter scan coverage is generally was there in the previous old generation CT scanners, but now we take a 8 centimeter or 12 centimeter scan which covers the entire brain. And we get, with a 40 ml of contrast at 4 to 5 ml per second with a 20 ml saline chaser, we get perfusion images. So what happens in perfusion, basically when we give the contrast, the dynamic first pass estimates the capillary level perfusion via serial imaging of the brain after administration of the IV contrast. So the attenuation in Hounsfield units is used to measure the ml of blood flow, that is per minute. So the flow is equal to volume per minute, as we know. It's called as a central volume principle. And this is the region of interest which we place the artery, that is the peak enhancement, and the venous output function. And then we get a graph like this. So the area under the curve is called the central blood volume. And this is the arrival time from the start of contrast injection to the enhancement within the artery. The tissue gets enhanced, and then there is loss of contrast entry into the vein. So the maximum time which it takes for the enhancement to occur is called the time to peak, and the transit time is the time from the artery to the vein. The slope of the curve is actually the CBF, which we are interested in. So in area of penumbra, what will happen? This is the CBV map and this is the MTT map. So mean transit time, whenever there is a vessel occlusion, the transit time will increase. So this is the total area, which is the core and penumbra. Whereas in the penumbral tissue, what will happen? The collaterals will try to accommodate for the cerebral blood volume, which stays to be normal or slightly increased. So here, the entire area here is the penumbra, which is salvageable. Whereas what happens in the core, you see the MTT is again elevated, which means both the core and penumbra, but the CBV tends to decrease. It appears to be blue or purple in color. So if it appears black, it means that's a very damaged and old core. So the entire area which shows a decrease in the cerebral blood volume is the core tissue. So all this is now we are talking about the advances. So we should know about the artificial intelligence, which is trying to replace and not exactly replace, but help us in the diagnosis and thus increasing the speed of our procedures is rapid AI, which is incorporated in the guidelines. Here the protocol is activated. It's a mobile app and it's linked to the hospital where it alerts the technologist, the radiologist, the neurologist, and the interventionist, the entire team in the workflow, sends the NCCT, automatically calculates the aspects ratio, and the CT angiography, after it is ordered, it will tell you the site of occlusion, and you can activate your emergency response team that you can go for the procedure, transfer patient to the emergency suite. It can also calculate the perfusion, the volume of the tissue, the mismatch volume can also be told. So another thing is patients can also undergo MRI. Wherever in your centers, the CT or MRI, whichever can be done faster, should be done first. MRI is a very important problem-solving tool because many patients will present with hypoglycemia and they are stroke mimics. So to rule out the other mimics, it is very important. And also for the posterior circulation stroke, the MR serves a very important tool in the further management of these patients. So in our hospital as well as internationally, we have the stroke protocol. It doesn't start with the T2-weighted sequence. However, it starts with the diffusion sequence, which should be the first sequence. And after that, we proceed with the flare, the gradient image, and the angiography. Perfusion, you can adapt or not. So the first sequence, diffusion, it beats the T2 signal within by 3 to 6 hours. It is the first sequence which will tell the area of damage. And diffusion weighted hyperintensity is seen in, you can see here in the left MCA territory, in the insular cortex, in the frontoparietal cortex, you can see a hyperintense area in the diffusion weighted sequences. We can have some color-coded maps, but they are generally not useful. There are some example of the posterior circulation small vessel strokes like the medullary infarction and lateral medullary syndrome and the medial medullary syndrome. You can see some small patchy infarcts in these areas. And this next sequence we see is the flare. So flare comes in approximately 4 to 6 hours. And if there is a flare negative lesion and their diffusion is showing positivity, that means there is a diffusion and flare mismatch. So those patients have a completely reversible penumbra, and those patients you should intervene. However, if there is a diffusion flare match, if you are seeing both single intensity in both the images, that means that area is completely damaged. Sometimes on flare, you can see some hyperintensity within the vessels. That can be due to slow flow or that can be exact thrombus. And in more than 90% of the brain tissues, we see the flare hyperintensity in more than 6 hours. So the next sequence we do is the susceptibility weighted image, which shows us the clot location, the hypointensity of the clot. And this is typically seen in RBC-rich clots, which are very responsive to therapy. So we can also see sometimes the microbleeds in elderly patients, which were earlier seen in hypertensive patients. And in guidelines, it was there that if you have more than 10 microbleeds, patients should not undergo thrombolysis, but that has been removed in the latest guidelines. And the last sequence which we can do before a MR angiography is the T2-weighted sequence, which can guide us to the location of the clot sometimes. The hyperintensity you can see in the left internal carotid artery, which is which is there. The normal T2 flow void is generally there in the contralateral ICA. After that, we do an MR angiography, which can tell us this clot location, and then we can go on to proceed with the intervention. But there are certain artifacts in the MR which we should be conversant upon. And perfusion can also help, just like the CT perfusion, we can have a non-contrast or contrast-based perfusion in MRI. Contrast is generally not required in the MR. It works on the similar principle, but we can compare the diffusion and perfusion areas and see amount of penumbra and the salvageable tissue. These are the advances in the MRI. Using high B values, we can see for patients who are having TIA, smaller strokes, the point of care MRI, the bedside MRI, the EPI-based faster sequences and parallel imaging. And not in the acute setting, but to evaluate the cause of stroke, carotid Doppler and transcranial Doppler can also be used. So this is about the imaging in stroke, how the workflow happens in the case of a patient when he presents in the diagnostic phase. And after once we have decided the treatment of the stroke patient has to be done and is presenting well within the window period, so we go on to proceed with the intervention. So interventions in stroke are life-saving. The effectiveness has been shown beyond any reasonable doubt. Generally, there is 30% recanalization and 25% good outcome with TPA, which is still slightly low in current era. So all patients should receive TPA and thrombectomy, which are well within the guidelines. And for that, we need to recognize the stroke, as I have already discussed, that is the FAST. And now it is added the balance and the eyes to incorporate the posterior circulation stroke. So the acronym now becomes BFAST. And this is the best thing to do. Currently, we are lacking in India on the ambulances. It's only in Coimbatore right now. But internationally, we have an inbuilt CT scanner unit within the ambulances where the patient undergoes a CT scan there itself. And once you rule out hemorrhage, the patient undergoes thrombolysis just immediately within the mobile ambulance. These are the trials which were conducted in 2015. The different parameters, the CT aspects, the CT angiography, perfusion, all were studied in different studies. And all of these studies eventually showed that there's a far superior outcome of mechanical thrombectomy as compared to best medical management. The p-values came out to be significant. And that's when the stroke guidelines were established in 2018 with a recent update in 2019, where they recommended that patients should undergo thrombolysis within a 4.5-hour window period, and mechanical thrombectomy should be performed in less than 24 hours in age more than equal to 18 years, the stroke severity index more than equal to 6, aspects more than equal to 6, ICA occlusions, the M1 occlusions, and the basilar artery occlusions. And how do we select patients? So this is a case where you can see a time since onset is 4 hours and an NIHS of 12. Here the aspect score seems to be good. There's only involvement of the external capsule, so aspects of 9. And when we do a CT angiography, you see that there is occlusion of the left M1 MCA. This is the DSA image.
Dr. Chirag, we are running short of time, so...
All right. So just 2 minutes, yeah. So after thrombectomy, we can see that there is complete opening of the vessel. So based on aspects and CT angiography in patients in less than 4.5 hours, we do a mechanical thrombectomy. For patients who are presenting more than 6 hours from onset, we need to do CT perfusion. Again, if there is a core penumbra mismatch, then we can take those patients. So this is the basic technique. Quickly, I'll show you. We take a 8-fan short sheath, the guide sheath, take our aspiration catheters, and take out the clot by suction. Or we can put in a stent retriever. This is the procedural video. So I'll skip it in interest of time. I'll show you a few examples. Here you can see that there is occlusion of the ICA terminus. And here the patient presented in 7 hours from onset. And within 15 minutes, we were able to recanalize the patient. Here you can see the core tissue by the loss of CBV in this area, but the entire right MCA territory, there is a lot of penumbra. So we took this patient for mechanical thrombectomy, just pushed our aspiration catheter inside, and this is the recanalization of the ICA terminus, and patient immediately lifted his leg on the DSA table. This is another example where you can see basilar artery occlusion, where aspiration catheter, aspiration technique is followed. We take our wire to the site of the clot and do the suction. And this is the basilar top occlusion, and this is the clot you can see which comes out through the suction mechanism. So these are different devices, the aspiration catheters, which are soft, long bore catheters, large bore catheters. Then there is some concept of if their clot doesn't come out, it can be due to white clots, which have a lot of friction. And this is one patient where we retrieved myxoma tissue from the brain because it was a cardiac myxoma which had embolized. This is the stent retrieval technique. In the MCA, you can see that there is a clot. The wire passes through the clot, and then we deploy a stent retriever. These are the different stent retriever, and then we pull out the stent, taking out the clot. So this is one example where you can see there is occlusion of the internal carotid artery. We take our microcatheter distally to the MCA, and this is the stent retriever with its markers, and this is the TK3, that is the grading of the recanalization that occurs. So we can do both combined aspiration and stent retrieval technique. And late window period, patients more than 6 hours, definitely we have already discussed the diffusion flare. Something which is outside the guidelines, but it is the recent advance, that distal vessel occlusions. Patients who are having, who's a singer and he has a speech deficit, it's a very disastrous condition for that. If I'm a radiologist and then I have a vision problem, so it's a very important for me to basically save my eyes, and for the painter, it's very important. So why not treat those patients who are having distal vessel occlusion? So absolutely yes, and we have got good results. Intracranial atherosclerotic patients, ICAD, which we say pediatric strokes, it's very devastating for children having a long-term paralysis. This is, and then we have transradial interventions. Going beyond 24 hours is under process of the studies. And octogenarians, patients who are more than 80 years, definitely we should consider treating those patients. So in conclusion, many techniques which continue to evolve. Every patient is different. Single technique which works well all the time, because we have to do cases at night time. 2 o'clock you will be getting a call. So you need to develop your own protocols, and the protocols have to be fixed. The goal is reperfusion. The TK3 recanalization is there, and there is a need for speed. The first pass effect is the best. So thank you for your attention.
Dr. Chirag, it was a very nice presentation vis-a-vis a diagnostic part. You have like very well elaborated how to proceed with the anterior circulation stroke, posterior circulation stroke, drawback of CT and posterior circulation stroke, and primacy of CT over MRI, where MRI helps over CT. I would like to ask, what is the success rate of mechanical thrombectomy vis-a-vis anterior circulation and a posterior circulation stroke? And second question is there any role of intra-arterial thrombolysis right now?
So these questions, if I stick to the guidelines say the posterior circulation stroke, and the most upcoming latest guidelines say that posterior circulation stroke, we don't make much of a difference to the life of the patient. But in my personal practice, as well as something which we have done, is that in basilar strokes, which are younger patients, less than 45 years, if we don't open those vessels, the patient is going to die 100%. There is no chance the patient is going to survive. So we do a MRI or a CT based, again, the posterior circulation aspects, and patients do recover, because we need to give them a chance. The results are very good. Definitely, patients have a huge morbidity if they present in late window. The earlier the patient presents, the posterior circulation gives us a lot of time, because there is a lot of collateral circulation, the perforators which are taken care by the posterior circulation. So earlier there was a guideline that posterior circulation can be treated up to 24 hours, but the anterior circulation can only be done up to 6 hours. But now it's okay for the anterior circulation also that we go beyond 6 hours. The outcome of anterior circulation for intervention is definitely better, because those patients already present in a good shape. They are presenting with just either weakness, or they are presenting with slurring of speech. But the posterior circulation strokes, those patients are presenting in intubated state, their GCS is falling down, so their pre-operative scale is already low. Why we are targeting those patients is to decrease the mortality rates, and more of the anterior circulation, we are taking those patients to decrease the morbidity data. So it's, although it's not comparable, but yes, I would say an overall 70% good clinical outcome would be there for both type of patients in case of doing a thrombectomy. As compared to, if your second question is on intra-arterial thrombolysis, again, that is not in the guidelines, but last week only we did one patient where aspiration technique failed. It was a distal vessel occlusion. One of the technician's wife had suffered from a distal vessel occlusion. She just had a focal weakness in, I think, her hand. And we did an intra-arterial thrombolysis. Patient presented at 7 hours. So patients who are presenting within 8 hours, which was earlier the guidelines, we can give intra-arterial thrombolysis. And that clot dissolved very well. We did a wire manipulation and dissolved the clot. And the patient had complete recovery. The patient was very happy. It's very difficult to convince patients who have a distal vessel occlusion, because they feel that, okay, I can live with the small weakness, grip weakness, I can live with that. But when they saw the result and had this thing, they were very satisfied. So intra-arterial thrombolysis definitely helps, but for patients, I would say maximum limit would be 8-hour window period, which I would follow.
Okay. Any questions?
Dr. Chirag, one question. If the patient lands in casualty within the golden period of 4.5 hours, you first go for IV thrombolysis. And if how much time do you give for that to act, and then you take up for thrombectomy?
Sir, so we first do a CT scan to rule out hemorrhage. If that's ruled out, we go ahead straight away with the thrombolysis, and we don't wait for the response of the patient. We directly go for a CT angiography on table, and then if there's a large vessel occlusion, we take the patient for mechanical thrombectomy. So the data which I see, it's basically a clinical and neurological, as well as a team we have of neurointervention radiologists as well as a neurologist, that decision we make based on the time since onset, how much damage is there already. And patients who have a distal vessel occlusion, like the M3, M4, MCA, they have a very good response to thrombolysis. But patients who are having a M1 ICA occlusion or a bifurcation occlusion of the MCA, those patients definitely have to be taken for thrombectomy, because the thrombolysis I have seen to be not be effective. So if we go from distal vessel, it is 75% for thrombolysis. It decreases to 50% at MCA bifurcation, decreases further to 25% at M1 MCA, and I have seen 0% recanalization with thrombolysis alone in patients who are having ICA occlusions. So we don't wait for the results of how the patient is going to do after giving a thrombolysis drug. It's just a basically bridging therapy. And if we are taking the patient for thrombectomy, earlier it was alteplase, which we used to give as a continuous 1 hour infusion. We used to stop it, but now we give a tenecteplase bolus. So that response, even if someone wants to see the response, although it's not in the guidelines, you should not waste time of the patient, because every minute the brain will tissue will be lost. But if you want to see, the tenecteplase will immediately give you response within 2-3 minutes or 5 minutes. So tenecteplase is a single bolus injection. So patients, if the distal vessel occlusion is there, patients will show immediate response. But that's not recommended to do.
Thank you.
Any question from audience? Okay. Thank you, Dr. Chirag.
Thank you very much.
Thank you, sir, for a spellbound and an engaging session. I would request our chairpersons, along with Dr. Shabnam Bhandari Grover ma'am and Dr. Devendra Singh, sir, to please felicitate our esteemed speaker. I would also request Dr. Archana Mehta ma'am and Dr. Shalini Srivastav ma'am to please join. I would request Dr. Shabnam ma'am, Dr. Devendra sir, Dr. Archana ma'am, Dr. Shalini ma'am to please felicitate our chairpersons. We will now be commencing with the next session, that is on widening horizons of minimal invasive surgery. To chair this session, I would like to invite Dr. Atul Gupta, sir, professor in the Department of General Surgery, JIMS Hospital, Greater Noida, Dr. Suresh Kalyan Sundar, sir, professor in the Department of General Surgery, SMSR, Dr. Kuldeep Raj Saragil, professor in the Department of General Surgery, SMSR, Dr. Vijay Anand, sir, assistant professor in the Department of General Surgery, SMSR. I would request honorable chairpersons to please introduce the distinguished speaker, Dr. Nikhil Gupta, Director, Professor, Department of Surgery, RML Hospital, New Delhi.
Dr. Nikhil Gupta, Professor, Department of Surgery, RML, New Delhi. You can already see his awards and accolades. And before it's not too late, let's start the session.
Good afternoon, respected chairpersons, senior faculty members, dear friends and colleagues. Thank you, sir, for the kind introduction. Greetings from my institute, Atal Bihari Vajpayee Institute of Medical Sciences and Dr. RML Hospital. I know I am standing between you all and your lunch, so no, I will try to be very brief. So widening horizons of minimal invasive surgery, at the outset, I would say, laparoscopic surgery or minimal invasive surgery, if not the greatest, but one of the, I will say, one of the greatest inventions in the field of a surgery. It has revolutionized our world, the general surgery as well as GI surgery. So before going on to the advancements, let's see from where it started all. Oh, thank you. So Kurt Seam was the first person who started doing laparoscopic surgery. He was basically a German gynecologist. You'll be surprised to know. The father of surgery, I will say laparoscopic surgery, is a gynecologist. So he started doing pelvic examination by laparoscopy in 1960s. Then while doing that, he invented his own instruments, and in 1982, he realized that few other surgeries are also possible with this technique, and he did first laparoscopic appendectomy in the world. But we surgeons are not very open for new ideas or for new inventions. He was also criticized. His article was rejected by American Journal of Gynecologists. Even the president of the German Association of Gynecology that time, he demanded that his license should be terminated. Then another German surgeon, Erich Muhe, in 1985, he was inspired by Kurt Seam, and he did first laparoscopic cholecystectomy. But again, he also faced a lot of criticism. Even his fellow colleagues labeled his surgery as a Mickey Mouse surgery. One of his patients died also, so he was also labeled as a manslaughter. Then in 1987, French surgeon Philippe Mouret, and there were few other surgeons in North America, they did laparoscopic cholecystectomy. Their study was recognized. And in 1990, the Society of American Gastrointestinal Endoscopic Surgeons, also known as SAGES, they, in their annual conference at Atlanta, they gave credit of doing first laparoscopic cholecystectomy to Philippe Mouret. But later on, the whole world came to know it was not the Philippe Mouret, but the Erich Muhe, a German surgeon who did the first laparoscopic cholecystectomy. And in 1998, SAGES also realized their mistake, and they gave this credit to Erich Muhe for doing first laparoscopic cholecystectomy. So we often use these terms interchangeably: laparoscopic surgery, keyhole surgery, MIS or MAS. Are these terms the same? Bit of a difference, I will say. Laparoscopic, it's a Greek, it has got derivation from a Greek word. Lapros means flank, and scopy means to examine. So basically, we reserve this term for abdominal procedures, right? But we know that the minimal invasive surgery is not limited to abdomen only. Nowadays, we are putting scope probably everywhere, whether it is thorax, whether, it is lower limbs, or it is even the neck also. So the better term will be a minimal invasive surgery or the minimal access surgery. But if we are using this term as a laparoscopic surgery, it means we are talking about the abdominal part only. What are the operations which we are doing laparoscopically commonly, or most of the centers are doing these procedures? It started with gallstones, then appendicitis, then hernia, adhesions, perforated gastric or duodenal ulcer, hiatus hernia, hydrated disease of the liver, in which we do a pair technique, percutaneous aspiration, injection and re-aspiration, then sigmoid diverticulitis, bowel prolapse, rectal prolapse, benign kidney disease, renal transplant. Laparoscopic donor nephrectomy is very good for the donors. Then gastric obstruction, some splenic disorders in which we can do a laparoscopic splenectomy. Then malignancy, right colon, left colon, and bariatric surgery for morbid obesity, either in the form of a sleeve gastro. Breast approach. As you can see in the image, 4 ports are inserted, 2 in the anterior axillary line and 2 at the areola, both sides, and we can approach the thyroid nodule with the help of this 4-port technique. The other technique is TOITVA, that is transoral endoscopic thyroid surgery, in which we insert 3 ports through the lower lip from the mucocutaneous junction. And both these techniques are, for those patients who are very cosmetically, I will say, conscious, and they don't want any kind of a scar in the neck. For those patients, we approach thyroid either from the axilla and breast or from the lower lip. BABA and TOITVA. Coming down, VATS, that is video-assisted thoracoscopic surgery or video-assisted thoracoscopy. Again, a very good approach for thoracic pathologies. It started with for chronic empyema, in which we can do debridement, we can do decortication, segmentectomy, lobectomy, pneumectomy. Then we can also we can do lymph node biopsies via this approach. And in thoracoscopy, we even do not need to create a pneumoperitoneum, because there is obviously a space between the costal cartilage, which is a rib-bound structure, and it doesn't require any CO2 to insufflate, and normal instruments can be used to do a thoracoscopy. We can do thymectomy also with the help of a VATS approach in patients suffering from myasthenia gravis. Similarly, mobilization of esophagus for patients suffering from middle 1/3 of esophagus. Again, a very good approach in which whole of the thoracic incision can be avoided with the help of a VATS, and you can mobilize whole of the esophagus from GE junction to the upper 1/3 of the esophagus. SEPS, again, a good approach known as a subfacial endoscopic perforator surgery, done in those patients who are suffering from varicose veins because of incompetent perforators. Only 2 ports are required, one for the camera and another one is to clip the perforator, or we can use an energy source with the help of that. Again, a minimal invasive approach. Patient recovery is very fast. A few of my papers, which I'm showing these papers to tell you that most of these surgeries can be performed at most of the centers without using any special equipment or technology or infrastructure. All those centers who are doing laparoscopic cholecystectomy, they can perform all these procedures. Other specialties, apart from general surgery, which are using minimal invasive surgeries, are urology. Urologists, they are doing nephrectomy, pyelothotomy, PCNL, URS, pyeloplasty, cystectomy, VVF repair. Similarly, our gynae colleagues, they are now doing most of hysterectomy via this approach. Laparoscopic assisted vaginal hysterectomy or total laparoscopic hysterectomy. Then ovarian cystectomy, diagnostic laparoscopy for infertility, myomectomy, taking care of ectopic pregnancy. All these things can be managed by a minimal access approach. Now, what are the principal differences between laparoscopic and open surgery? Obviously, post-operative pain will be less. If we talk about 3-4 decades earlier, the common dictum was big surgeons make big incisions, right? Bigger the surgeon, bigger will be the incision. From xiphis sternum to the pubic symphysis, We all have gone through that stage. But nowadays, it is totally the other way around. Big surgeon, small incision. From small surgeon, now we are going into the field of a no incision. Like nodes are natural orifice surgery, in which few surgeries can be performed from natural orifice, either it is rectum or vagina or from transoral approach. So smaller the size of the incision, less will be the postoperative pain, lesser handling of the intestines, obviously, less postoperative ileus, and patient can start taking orally early. Patient's hospital stay will be less. Patient can be discharged from the hospital very soon. He can resume his normal activities early. What are the advantages for the hospital? Yes, it carries a definitive initial cost to the hospital. The laparoscopic set with the hand instrument, it will cost you about 30 to 40 lakhs in the beginning, but it will reduce overall cost by shortening the hospital stay. Like open cholecystectomy, the hospital stay was roughly 4 to 5 days, wherein laparoscopic cholecystectomy, now the stay is even less than 24, I will say. Most of the centers are doing it as a daycare procedure. Patients are admitted in the morning, they will undergo surgery, and they will be discharged by late evening. Similarly, for hiatus hernia, if you do it in an open fashion way, patient will stay in the hospital 7 days. Whereas laparoscopic hiatus hernia repair, patient will stay only for 2 to 3 days. Now, what are the advantages for the surgeon? We have talked about the patient, for the hospital, for the surgeon. Yes, it's a magnified view. Tactile response is there, it is altered, but it is not absent. And we often get a 2D view because we are viewing the thing on a flat screen. Nowadays, we are also getting a 3D technology in which we get a 3D view. But conventionally, laparoscopic surgery is done by viewing on a flat screen, which gives us a 2-dimensional view. That's a bit of a restriction for the surgeon. Usually, I will say a longer operating time if surgeon is in his learning phase. But once surgeon has crossed his learning phase, then I will say operating time is same, or sometimes in some surgeries it is less than the open surgery, because the time to open and to close the incision will be absent in a case of a laparoscopic approach. As you know, this is the still picture of a laparoscopic cholecystectomy procedure in which a surgeon is applying clips over the cystic duct. We can do removal of stones from CBD via laparoscopic manner, which has definitive advantages over ERCP. ERCP is I will say the preferred approach for managing CBD stones, but it has its own disadvantages. Like patient has to undergo a procedure twice. First, he will undergo ERCP followed by laparoscopic cholecystectomy. Plus, ERCP has few complications, or inherent complications, like in the form of a pancreatitis or duodenal perforation, whereas laparoscopic cholecystectomy plus CBD exploration will be I will say one-stage procedure, which can tackle both gallstones as well as the CBD stones, plus the sanctity of the sphincter will remain intact, and all the complications of ERCP can be avoided with the help of a laparoscopic CBD exploration. So we have published this study in surgical endoscopy in 2012, and by that time it was the largest series, because the type of CBD stones which we face in this part of the world, they are difficult to tackle via ERCP, because the stones which we get, they are quite big in size and they are impacted. So via endoscopic or by ERCP manner, it will be difficult to remove them. So laparoscopic CBD exploration is a very good procedure for our patients. Nissen fundoplication for patients suffering from GERD, reflux disease, or patients suffering from hiatus hernia. Again, a very good technique, because it is very difficult to reach the hiatus via open surgery. Laparoscopic surgery not only gives us an easy access, but also a magnified view. So fundoplication, either a Nissen fundoplication or a Toupet fundoplication, is, I will say, easier laparoscopically rather than an open method. Inguinal hernia repair, again, a very good procedure to be done laparoscopically. Various approaches for laparoscopic hernia repair are there now, whether it is TEP, that is total extraperitoneal repair, or TAPP, transabdominal preperitoneal repair. In both these procedures, the only difference is in the approach. But ultimately, we have to go in the preperitoneal space to reduce the hernia sac, and then we place a big mesh there, about 14 by 12 centimeter polypropylene mesh, which covers the myopectineal orifice of Suchard, which is a potential area of weakness which gives rise to direct, indirect, and obturator hernia. So, by a laparoscopic method, we can cover the whole myopectineal orifice, which is a potential site of weakness, which is not possible in an open hernia repair technique. And again, it gives all the advantages of minimal access surgery, whether it is less post-operative pain, less hospital stay. And again, this procedure is also being done as a daycare procedure at most of the centers. Appendicectomy, a 3-port technique, again, a good technique to be done, a good surgery to be done laparoscopically. Otherwise, conventionally, a big incision was to be given about 6 to 7 centimeter in right iliac fossa. But with this technique, with 3 5 mm ports or maximum 1 10 mm and 2 5 mm ports, we can carry out our surgery and we can remove the appendix. Rectopexy, commonly done for rectal prolapse, in which we mobilize the redundant segment colon and the proximal rectum, and we place a big polypropylene mesh between the mobilized colon and the sacrum. Via open technique, it requires a big infraumbilical incision, which carries all the potential complications of a wound infection and incisional hernia. This operation can also be done laparoscopically. Laparoscopically, we can mobilize the colon and we can place a mesh and we can fix it with the sacrum and with the colon. Ventral hernia, epigastric hernia, umbilical, paraumbilical, incisional hernias, all these hernias can be taken care of by a laparoscopic approach in the form of a IPOM or IPOM plus. In IPOM, we reduce the hernia and we place a composite mesh and we fix it with tackers or with the sutures, whereas in IPOM plus, we first close the defect and then we place a composite mesh. In composite mesh, the one side is a non-absorbable surface, whereas the other side is coated with a substance which will prevent adhesions between the bowel loops and with the mesh. As you can see, we have reduced the contents and this is the defect which we can see. And now in the other picture, we can see we are fixing the mesh with the anterior abdominal wall using the tackers. In this study, we have compared the absorbable tacks versus non-absorbable tacks, and we found there was no difference in the post-operative pain. The only difference was in the cost, because absorbable tacks, definitely they are expensive as compared to non-absorbable tacks. Cystogastrostomy, done for pseudocyst of pancreas, in which we make a communication between the posterior wall of stomach and the pseudocyst, which is lying there in the retroperitoneum. So again, it can be very well be done with the help of a laparoscopic approach, and this communication can be achieved either with the help of a linear stapler or with the help of a monopolar cautery and suture. Bariatric surgery done for morbid obese patients. Guidelines are either the patient's BMI should be more than 40 for Western world. For Asia Pacific population, the cutoff is BMI should be more than 37.5 or it should be more than 32.5 plus comorbidity. Patient should be motivated and he or she must have tried all the non-surgical methods to reduce the weight. Then we can offer him or her either a sleeve gastrectomy or a bypass in the form of a mini gastric bypass or RYGB. This bariatric surgery also became popular with the advent of laparoscopic surgery only. 100% of these procedures are done laparoscopically, bariatric surgery. No one in the world will allow you to do a bariatric surgery via open approach, because these patients are obese, they are high-risk patients, they are having multiple comorbidities. So opening their belly via open approach will be hazardous for these patients. I will say it will be life-threatening for them. So via laparoscopy, you can do all these procedures, and patients are able to lose their 70 to 80% of their excess body weight. As you can see in this image, we are dividing the 80%, we are removing the excess part of the stomach with the help of a endo-GI stapler. Donor nephrectomy for patients who are requiring renal transplant because of CKD. The donor who is actually not a patient, but he's just giving his kidney to either his friend or his relative. We can offer laparoscopic approach to these patients. Kidney can be mobilized and clipped, and then we can give a small incision in the flank to deliver the donor kidney. Less incision, less pain, less post-operative complications, less incidence of wound infection, less incidence of incisional hernia in the post-operative period. Adrenalectomy, again, a very good procedure, can be done by a 3 or 4 port approach in the subcostal region. Again, via open technique also, it is not very easy because of its location. But by laparoscopy, it will give you a magnified view and we can directly access the adrenal. We have to clip the adrenal vein, we have to mobilize it from the liver, from the underlying kidney, and we can remove it. SILS. SILS came about, I will say, a decade earlier. single incision laparoscopic surgery. As you can see in the image, we only have one port. It's a multi-port in which there are 3 or 4 channels, mostly 3 channels. And from these channels, we can introduce our scope and we can introduce our hand instruments. So patient will be having only one incision, about 14 to 15 mm at his or her belly. And most of the procedures, whether it's gallbladder, hernia, or bariatric, can be done via this approach. As you can see in the sideways image, the instruments are curved. They can be curved to do all the desired manipulation. And then came the improvements in the quality of vision. Like I told you earlier we were doing laparoscopy on a 3D image. We were seeing only the, or we were watching on the flat screen in which the 2D image was perceived to us. But then the companies came up with the idea of 4K and 3D. 4K will give you 4 times the resolution of full HD. And it is said that 4K will show you even better than the normal eye. What you can see with your normal eye without specs, 4K will be 4 times better than that. The resolution of 4K Ultra HD is, as you can say, 3840 into 2160. And full 4K resolution is 4096 into 2160. Extremely, extremely wonderful resolution. Minor blood vessels, small threads, small adhesions, everything is so beautifully visible, you cannot skip. So obviously you can achieve a very good hemostasis, your dissection, your adhesolysis, everything will be great if you have a wonderful imaging and a great magnification. 3D high definition view will give you a 3D image. The screen is curved. Surgeon also uses the glasses, just like you watch any 3D movie in PVR. So in 3D imaging system also, the surgeon has to wear 3D glasses. Again, the vision is very good, and the depth perception will also be there. ICG, indocyanide green dye, it was developed by Kodak company for near-infrared photography. This dye is exclusively excreted by the liver in 8 minutes, and this quality is utilized by the hepatobiliary surgeons for doing, cholecystectomy, CBD exploration, liver resection. The standard clinical dose, as you can see, is 0.1 to 0.5 mg per ml per kg. It becomes fluorescent once excited, either using a laser beam or by near-infrared light. It means for this, you have to use a separate system, ICG system. With the normal laparoscopic cart, you will not be able to use this ICG. You have to use a separate system for this. It is detected using specifically designated scopes and camera. As you can see in the image, excreted exclusively by the liver, and then it enters into the hepatobiliary system. So in the cases of a frozen calyx, or when the anatomy is unclear or there is aberrant anatomy, ICG is very useful. Where the cystic duct is, where it is opening, where the common hepatic duct, where the common bile duct. So you can very well be clear about your anatomy part. So it helps you in difficult laparoscopic cholecystectomies. Many surgeons are also using it for the bowel anastomosis because it also tells you the vascularity of your anastomosis. If your anastomosis is not having a good vascularity, then you can always revise it. So especially useful for left-sided colorectal malignancies. Intraop ultrasound is also of a great help to the surgeons. The ultrasound transducers, they convert electrical energy to sound wave energy via piezoelectric crystals. We all know advantages, real-time imaging and avoidance of ionizing radiation in the OR. Now, since we are doing this laparoscopic or the minimal access procedures to take out few organs like spleen, kidney, or colorectal, so while delivering these organs from the abdominal cavity, if they come into contact with the abdominal wall, they can give rise to wound infection. So many companies now, they have come up with wound protectors in which there are 2 rings. One ring goes inside, another ring remains outside, and both rings are connected with a bag of a polythene, you will say, or a plastic. So if you deliver the organ through this wound protected device, the organ, the bowel, the spleen, the kidney will not come into contact with the abdominal wall. So chances of wound infection will be quite low. What is Botox? We all know the most common use of Botox, but here we are talking about the uses of Botox for complex ventral hernia. Complex ventral hernia in which there is loss of domain when most of the abdominal contents are lying outside. And if you try to put those contents back into the abdominal cavity, patient might develop abdominal compartment syndrome. So we have to increase the capacity of the abdomen and we have to relax the abdominal muscles. So Botox helps us in causing relaxation of the abdominal muscles. 2 weeks prior to the surgery, we inject 50 units of Botox in external oblique, internal oblique, and transverse abdominis muscles at 3 sites on each side. Total dose is 300 units. It causes flaccid relaxation, elongation and thinning of the lateral abdominal muscle fibers, and decrease in the hernia defect. So your repair will become easy and your contents may go inside. In these cases, we also take help of a preoperative pneumoperitoneum. Like I've told you, there is less intra-abdominal space. So we take up these patients for creation of pneumoperitoneum or 2 or 3 times before taking them for definitive surgery. Progressive pneumoperitoneum is recommended. A dialysis catheter is inserted in the abdominal cavity with a 3 centimeter lower midline incision under local anesthesia, and this procedure can be repeated as indicated. TAMIS, transanal minimal invasive surgery. It's also a part of a NOTES or a natural orifice surgery, as you can see in the slide. A specially designed port, which is there at the anal canal, and we can remove small anal or rectal polyps or early malignant growths with the help of this technique. Minimal access surgery has made ERAS possible, enhanced recovery after surgery, because obviously these patients will be having less post-operative pain, they will start taking liquids early, they will be ambulatory early, they can be discharged early. So now for most of the surgeries we have ERAS protocol, and that is possible only because of a laparoscopic surgery, I will say. This is future for us. Robot. Surgical robots history goes back to 2007. Da Vinci was the first company, who designed the surgical robot. They got FDA approval in 2002. Surgeon might be sitting in a different room, in a different city, in a different country, or in a different continent. So can you imagine this? Surgery is going on in one continent, surgeon might be sitting in some other continent, right? And with the help of a technology, he is having full control over the surgery. Surgery is not being done by the robot. Robot is only following the commands or the orders given by the master sitting on the robot machine. So, as you can see, cholecystectomy was first performed by telesurgery from 300 miles away. First robotic prostatectomy was done in 2001. Nowadays, many companies have come up after Da Vinci, and their robots are even cheaper than Da Vinci. The advantages of robotic surgery is obviously magnified view, much magnified than laparoscopic procedures, about 12 times. It gives you a 3D vision. Robotic wrist has 6 degrees of freedom, whereas laparoscopy has only 3 or 4 degrees of freedom. So the suturing part is very easy via robotic approach if you compare it with a laparoscopic approach. Movements are much scaled, filtered, and translated. Disadvantages, yes, it's an expensive procedure. It increases the cost of surgery by 2 to 3 times. Consumables are quite expensive. They are for one-time usage only. Learning curve is also steep. And the whole of the staff, your technicians, staff nurses, everybody has to be trained. Applications, both in urology, cardiac, gynae, general surgery, everybody can use according to their needs. Limitations, robot has no advantages over standard laparoscopic approach for basic procedures like gallbladder, splenectomy, or colectomy. For these procedures, it will only increase your cost and your OT time. No extra advantage to the patient, right? Future again, AI is coming in a big way. Nowadays, we are using AI for surgical stimulation. The AI will tell you which is the no-go zone area and which is the green zone area where you can enter. Robotic rounding is a reality. Surgeon will be either at his home and the robot will be taking rounds. Surgeon will be on the monitor. He will ask questions. He will give instructions. Robotic scrub nurse. So probably after 4 to 5 years, you will be not having a beautiful nurse standing next to you. You will be having this machine. You will be asking him or her for instruments. So this is our future OR. So I will say at the end, the technology is neutral. It is neither good or bad. It is the surgeon who has to take control of everything. We have to pass on the benefits of technology to the patient. And we have to apply all these technologies with empathy and compassion for each and every patient. ultimately patient has to be benefited, right? If we are adding a cost to the patient's pocket without giving him any advantages, this technology or this innovative surgery will not survive. The advantages, all the benefits have to be transferred to the patient. Dialogue from my favorite serial, Star Trek, don't leave him in the hands of 20th century medicine. Those butchers will use needles and knife and cut open his belly. I hope the next generation will not use the same dialogue for us. So we have to evolve with time. We have to adopt to the new technologies, to AI, to robots. Otherwise, it will apply on us also. Thank you. Thank you.
Thank you very much, Dr. Nikhil.
Thank you.
Fantastic slides, procedures, and I'm sure, as you wish, the younger generation would take on to betterment in the technology and giving it to the patients. Thank you. Any questions from the audience, please?
Thank you for the lectures, Dr. Nikhil.
Thank you, sir. Thank you.
My question is, everything we are here for the patients, whether it's technology, surgeon, or whatever equipments are there. So how wise is, according to you, going through natural orifice surgeries, avoiding that 1 centimeter scars even?
Sir, I will say nowadays, we are like shopkeepers, no? We have to keep everything in our window, whatever surgeon asks for. Especially if you are sitting in a corporate area. Patient who is coming to you is very knowledgeable. He will do a lot of window shopping on Google. He will see what all is available. So he will see, okay, natural orifice, no incision. So we'll come to you, doctor, I have to undergo no incision surgery. So you will try to convince him that, nodes is not of much use, or it has no specific advantages over a laparoscopic approach. If we talk about transoral appendectomy, I will say if I have to undergo appendectomy, I will prefer a laparoscopic appendectomy. I will not like to go transoral, transgastric appendectomy. But you all know that, it has been done in the past. Though nowadays not many surgeons are doing that. But then also if a patient is very adamant, and if you will tell them that I do not do or I don't know how to do appendectomy via nodes approach, then patient will be having this option to go to some other center, to some other hospital. So you should be knowing about everything. We should be able to tell the patient pros and cons of each and every procedure. Then depending upon our expertise and the infrastructure where we are working, we can offer our services to the patient.
Thank you, Dr. Nikhil, for covering this vast topic.
Sir.
Because 3-4 lectures are also less for this vast topic.
Sir,
You have covered
absolutely,
in short
absolutely
time.
right.
And right now, I think everybody, except for I think maybe cesarean, every surgery is now possible with minimally invasive
Absolutely right,
surgery.
absolutely right.
And
But we don't know the future. Don't know the future.
and because now it's the lunch time, so rest of
Thank
the
you.
questions I think audience can ask during lunch time. Thank you.
Thank you, sir. Thank you.
Thank you, sir, for a captivating and stimulating session. I would request our chairpersons, along with Dr. Vikram Singh Chauhan, sir, Dr. Ravi Kale, sir, to please felicitate our notable speaker. I would also request Dr. Vikram Singh Chauhan, sir, and Dr. Ravi Kale, sir, to please felicitate our chairpersons. We will now take a short lunch break. I would request everyone to please join us for lunch outside. We will be commencing with the next scientific session after half an hour with full zeal and enthusiasm. Thank you.
Students, please be seated. We have arranged the food for you people also. You wait for 5 minutes or so, we will announce. Okay.
Join us for lunch, all my dear students, and get back and be seated by 2:30 p.m. again for the valedictory session. Is it fine?